Good evening, ladies and gentlemen. Welcome to our annual Congress of Kolkata Academy of Ophthalmology. We have to do it virtually and we miss you, of course, having in Calcutta. But this is the zeitgeist and we have to flow with the time. The ethos in Kolkata Academy has always been to utilize our knowledge for benefit of all our members, be a practitioner in far reaches of Sundarbans or Darjeeling, or maybe in a tertiary care hospital in Kolkata. Today's program follows that philosophy. We have the doyens of glaucoma world with us, and we are sure that with their wisdom and knowledge, we'll be able to fine-tune our treatment of patients who come to us in a general ophthalmology clinic or specialized glaucoma clinic. And with that thought, very happy thought in mind, I lead you on to our panel of moderators. Our moderators are actually exclusive glaucoma practitioners, and they're well known all over the world. Our president, Dr. Chandrima Paul, our secretary, Dr. Surajit, and our member of the governing body, Dr. Sumit Chaudhary, all of them are very well known. Dr. Chandrima Paul has been in exclusive glaucoma practice for the last 27 years, and she is the head of the department and director of BBI Foundation in Kolkata. Dr. Surajit has been a trainee from Aravind, and now he is a famous glaucoma specialist and head of the department of Madhurla. And Dr. Sumit Chaudhary, he has been in glaucoma practice as well for the last 3 decades. All of these will ensure, all of these characteristics in our moderators will ensure that we have a fantastic interactive session. Thank you so much. I hand you over to our president, Dr. Chandrima Paul.
Thank you very much, Rajesh. Thank you for those kind words. I shall share my screen to introduce the faculty. Today's faculty, each and every one of them actually need no introduction, but it's customary to do so. And that's the reason I'm going ahead with it. I'm starting with, just a second, I'll just minimize this. Yes. I'm starting with our key opinion leaders. They're going to give the keynote address. Dr. G. Chandrasekhar, Vice Chair, LV Prasad Eye Institute, past President, Glaucoma Society of India, past member, Board of Governors. The slide is not moving. He's a past board member of the Board of Governors of the World Glaucoma Association. I was indeed very lucky to be the East Zone representative of the GSI during his tenure as the president of GSI. And I'm ever grateful to you, sir, for going all the way to my college, Silchar Medical College, to conduct a GIEP program with me. A very warm welcome to you, sir. Dr. J.C. Das, Chief of Glaucoma Services, Shroff Eye Center, senior most glaucoma practitioner in the country. He has been the president of the Delhi Ophthalmological Society and recipient of the Lifetime Achievement Award of DOS. Past president of the Glaucoma Society of India. He is the man behind introducing Ahmed glaucoma valve in glaucoma management in India nearly 20 years back, which is his greatest contribution. He's always been a mentor and a teacher to me in my past nearly 2 decades of journey in the Glaucoma Society of India. A very warm welcome to you, sir. Dr. Harsh Kumar, awarded the Padma Shri for the year 2015, past president of the Glaucoma Society of India, former teacher at the RP Center for Ophthalmic Sciences at AIIMS, New Delhi. Sir has been one of the best teachers that I have ever met, and he has always traveled to Kolkata on our request to teach us. A very warm welcome to you, sir. I move on to our speakers for this evening, Dr. Mayuri Khamar. She's going to speak on treatment of advanced primary open-angle glaucoma. She's a glaucoma specialist for more than 30 years, ex-associate professor, recipient of multiple awards from the GSI and AIOS, published research articles in previewed journals, held organizational posts at state and national levels. A very warm welcome to you, Dr. Mayuri. Dr. Shefali Parikh will be speaking on generic versus brands review, is an ex-consultant of LVPI Institute, Hyderabad, Advanced Glaucoma Fellowship from the Lund University, Sweden, directors Regi Eye Clinic and Palex Glaucoma Care Center, which is a high-tech, fully equipped, state-of-the-art tertiary glaucoma center located in Mumbai. A very warm welcome to you, Dr. Shefali. Dr. Pradeep Vyas, currently the medical director at the Center for Sight, Indore, done his post-graduation from Indore, then fellowship from LB Prasad Eye Institute, Hyderabad, was the founder MD at Sri Ganapati Netralaya, Jalna, and Chotiram Netralaya, Indore. He would be speaking on New Kids on the Block, New Drops. A very warm welcome to you, sir. And I'll never forget the Jalna conference, which we attended of the GSI, where you had air conditions, makeshift halls. Wonderful organizational capacity. A very warm welcome to you. Dr. S.S. Pandav, Professor of Ophthalmology, Glaucoma Services, Advanced Eye Center, Postgraduate Institute of Medical Education and Research, Chandigarh. Sir will be speaking on new drug delivery systems this evening, and a very warm welcome to you, sir. Dr. Ronnie George, the Deputy Director of Glaucoma Services, Shankar Netralaya, Chennai. He would be speaking on nocturnal IOP in glaucoma management. A very warm welcome to you, Dr. Ronnie. Dr. Saithan P. He has been the Chief in charge of glaucoma services in the Aravind Eye Hospital, Coimbatore. He's been the Secretary of the Glaucoma Society of India, Director of Saithan Eye Care Hospital at Coimbatore, would be speaking on laser PI. A very warm welcome to you, Dr. Saithan. Dr. Kirti Singh, Director Professor of Ophthalmology, Guru Nanak Eye Center and Maulana Azad Medical College, New Delhi. Glaucoma Fellowship from Wills Eye Hospital, USA under Professor George Spaeth. Publications in 50 index, 75 peer-reviewed journals, and 12 textbooks of ophthalmology. Would be our rock editors here to stay. Welcome to you, Dr. Kirti. Dr. Jyoti Bhatt, eminent faculty in Sitapur Eye Hospital with wide expertise in the field of glaucoma, would be speaking on the equation of systemic medications and glaucoma. A very warm welcome to you, Dr. Jyoti. Dr. Shahinur Tayab did her fellowship in glaucoma from Shankar Netralaya, Chennai, junior consultant at Sri Shankar Deva Netralaya, present executive member of the East Zone of GSI, would be speaking on laser trabeculoplasty. A very warm welcome to you, Dr. Shahinur. Dr. Manavdeep Singh, professor at the Glaucoma Services of the ABVI MS and Dr. Ram Manohar Lohia Hospital, New Delhi, present treasurer of the GSI and library officer of DOS, will be speaking on medications in glaucoma patients with corneal disease. A very warm welcome to you, Dr. Manavdeep. Dr. Barun Nayak, head of the Department of Ophthalmology, PD Hinduja Hospital and MRC, President-elect All India Ophthalmological Society, Secretary Glaucoma Society of India, Editor Journal of Clinical Ophthalmology and Research, would be speaking on prescribing errors in glaucoma clinics. A very warm welcome to you, sir. Dr. Shweta Tripathi did her fellowship from Shankar Netralaya, Chennai, currently a senior glaucoma consultant at Indira Gandhi Eye Hospital and Research Center, Lucknow, would be speaking on glaucoma compliance facing the challenge. A very warm welcome to you, Dr. Shweta. Dr. Arijit Mitra, recipient of the D.B. Chandra Disha Award 2014, glaucoma fellow at Aravind Eye Hospital, ex-consultant at Aravind Tirunelveli, and presently consultant at Disha Eye Hospital, would be presenting a case on post-PI debacle. A very warm welcome to you, Dr. Arijit. Dr. Dipanjan Paul, senior consultant and cataract and glaucoma services at the Disha Eye Hospitals, presentations at national and international conferences and publications in peer-reviewed journals. A very warm welcome to you, Dr. Dipanjan. Dr. Shibal Bharatiya is an ophthalmic surgeon with special interest in diagnosis and management of glaucoma and ocular surface diseases, senior clinical research fellow in glaucoma services of the Department of Clinical Neurosciences, University of Geneva, and senior research associate at the Dr. R.P. Center of Ophthalmic Sciences, AIIMS, New Delhi, is the managing editor of the Journal of Current Glaucoma Practice, the official journal of the International Society of Glaucoma Surgery. A very warm welcome to you, Dr. Shibal. Dr. Ashok Kumar Nanda, the founder director of Kar Vision Eye Hospital in Bhubaneswar, specializes in cataract and refractive surgery and treats glaucoma cases as part of community eye care initiatives. A very warm welcome to you, Dr. Nanda. Dr. Nazneen Nizam, long-term fellowship in glaucoma, working as assistant professor in the ESI Medical College and Hospital in Kolkata, keen interest in glaucoma and neuro-ophthalmology, would be presenting a case titled A Bolt from the Blue. A very warm welcome to you, Dr. Nazneen. Dr. Shukanda Mitro did her fellowship in Shankar Netralaya under the late Dr. Sridhar Rao, She works as a glaucoma consultant at Silverline Eye Hospital and Purva Eye Care and has over 25 years of experience in glaucoma. A very warm welcome to you, Dr. Shukonna. Dr. Mumtaz Alam, senior cataract and glaucoma surgeon, has operated on many one-eyed patients at the Disha Eye Hospital, West Bengal. A very warm welcome to you, Dr. Mumtaz. Dr. Shutapa Roy, done glaucoma fellowship from Shushruth Eye Hospital and Research Center, working as glaucoma consultant since 2011, presented various papers in state and national conferences. A very warm welcome to you, Dr. Shutapa. Dr. Pallavi Raj is a consultant in glaucoma and cataract services at Shankar Nethralaya, Kolkata. Her areas of interest include secondary glaucomas and drainage devices. She would be presenting a case titled Microspherophakia. A very warm welcome to you, Dr. Pallavi. Dr. Maitri Das did her fellowship from Shankar Nethralaya, Chennai, is practicing glaucoma for the last 23 years at Eye Foundation and Research Center, Kolkata. She is a glaucoma faculty at Institute of Eye Care, Kolkata. A very warm welcome to you, Dr. Maitri. Dr. Ankur Sinha practices at the Eye Clinic in Dehradun, completed MD from AIMS and specializes in squint and glaucoma surgery. A very warm welcome to you, Dr. Ankur. Dr. Sagar Bhargav, fellowship from Shankar Nethralaya, Chennai and ex-deputy director at Shankar Nethralaya, Chennai, senior consultant at cataract and glaucoma services at the BBI Foundation, Kolkata. A very warm welcome to you, Dr. Sagar. Dr. Tomanash Basu, associate consultant at Shankar Nethralaya, Kolkata, looks after glaucoma, cataract and anterior segment diseases service, is editor of the popular online ophthalmic teaching portal eOphtha, is going to present a case, Can SLT Help? A very warm welcome to you, Dr. Tomanash. Dr. S. Kavita, HOD Glaucoma Services at Aravind Eye Hospital, Pondicherry, key investigator of landmark trial Indian family angle closure evaluation of Aravind Eye Care System in collaboration with the Wilmer Eye Institute. At present, she is analyzing the impact of shared medical appointments in glaucoma care provision in collaboration with London Business School and Harvard Business School. A very warm welcome to you, Dr. Kavita. Dr. Rita Das, senior consultant with 23 years of experience at corporate multi-speciality hospitals, research institute and medical colleges, faculty at GSI and thesis guide to DNB students. A very warm welcome to you, Dr. Rita. Dr. Shaumendra Nath Ghosh, after completing fellowship at Aravind Eye Hospital, Madurai, he is working at Disha Eye Hospital as cataract and glaucoma consultant for the last 7 years, has multiple presentations at national and international conferences and few publications in index journals. A very warm welcome to you, Dr. Shaumendra. With that, I come to the end of the introduction, and I would request our first keynote speaker, Dr. G. Chandrasekhar, to please go ahead with his presentation. You can share your slides, sir.
Yeah, am I audible and the slides visible?
Yes, sir.
Thank you, Chandrima, for the kind invitation and the privilege of sharing some thoughts on the glaucoma suspect this evening. Without much ado, I will get on to the topic. We define glaucoma as a primary progressive optic nerve disease with typical changes in the optic disc or nerve fiber layer and the visual fields. We all know that intraocular pressure is only a risk factor. In the context of talking about glaucoma suspect, clinically we have to deal with situations where the intraocular pressure is raised, or the anterior chamber is shallow, or the most important topic would be whether we are dealing with a preperimetry glaucoma or is it a normal variant of the optic disc appearance. I will try to address these three issues. In the context of a raised intraocular pressure with apparently normal anterior segment, one would talk in terms of ocular hypertension. It's essential that we make sure that the angle is open with appropriate gonioscopy, as I will address subsequently, and whether the raised intraocular pressure is an erroneous recording because of the changes in corneal thickness or the instrument errors is something that we need to be cognizant about. Much is talked about the changes in corneal thickness affecting the intraocular pressure. In my opinion, the only study that validates truly the effect of intraocular pressure, effect of corneal thickness on intraocular pressure is this manometric study. The data from this study shows that if the corneal thickness increases by 70 microns, the intraocular pressure measurement error is 5 millimeters of mercury, and the normal corneal thickness that is taken for this Baseline corneal thickness that is taken for this is 520 microns. If you see the top row, if the corneal thickness is less at 450 microns by 70 microns, 450 microns, then at an intraocular pressure of 10, the underestimation is 4. At an intraocular pressure of 30, the underestimation would be 6. As opposed to that, if the corneal thickness is increased by 90 microns at 590, the variation in intraocular pressure is not that much compared to the gold standard of 5. This goes to drive home the point that you cannot afford to correct the intraocular pressure per millimeter by the changes in corneal thickness by micron. It's only a rough approximation that we need to remember. A lot of new technologies are there that claim to be independent of corneal thickness. This is one such instrument that we need to be aware of, Pascal stonometry. The largest database that we have of comparison of Goldman with Pascals does show that with increased corneal thickness, the Pascal also does overestimate intraocular pressure. All the other new technologies that we have their own limitations. Majority of them are indentation tonometry principle. They may be able to give a lot of other new variables, but their relevance in the practical glaucoma diagnosis and management is still highly wanting. The most important point as far as intraocular pressure that we need to take home is a non-contact tonometer is a no-no as far as diagnosis and management of glaucoma is concerned. This 38-year-old lady went on having increased medications because the intraocular pressure was not controlled and finally was advised surgery. When we saw her, the discs were healthy and the angles were open. We managed to discontinue all the medications over a period of time and the intraocular pressures remained normal. So non-contact tonometry cannot be used for making diagnosis or management of glaucoma. Moving on, the other points that we need to remember is if the intraocular pressure is consistently more than 30, then there is an argument for treating the intraocular pressure alone. Or if the intraocular pressure is between 20 and 30, but there are risk factors for retinal venous occlusions in the elderly age group, one can go ahead and start treatment in those situations. As far as gonioscopy or shallow anterior chamber is concerned, we need to remember that the most important decision we need to make is to differentiate between primary angle closure suspect and primary angle closure. There is no indication for treating all suspects, but the moment you see a primary angle closure, laser iridotomy is indicated. From that perspective, it is important to remember that the ideal conditions where the pupil will dilate to its maximum and then assess the gap between the cornea and the iris to assess whether the angle is occludable or not is the first important step. Just touching briefly upon the advanced technologies that we may have, they all will help us only in diagnosing primary angle closure suspect. But to diagnose primary angle closure, we need to pick up the subtle changes in the angle like this, which shows a blotchy pigment. From that perspective, this is a closed angle on testing condition 1, and on indentation, the angle opens up. The trabecular mesh for pigmentation is irregular with a blotchy pigment. That is a definite sign of primary angle closure that will require treatment. Once again, what looks like an open angle can be pigmentation on the back of the cornea. With indentation, one can make out that, and this is actually an angle closure that requires treatment. What looks like a synechia like this can disappear on indentation. So one needs to be careful about evaluating the gonioscopy and ruling out pseudosynechia like this on a good indentation gonioscopy. Moving on, the most important topic that we need to address is the preperimetric glaucoma or suspect that we are seeing. From that perspective, you might have a large physiological cupping that looks like glaucoma. You may have a tilted disc that looks like glaucoma and not following the ISNT rule. You may have a congenital disc anomaly. You may have a tilted disc with myopia that will confound your diagnosis of glaucoma. In those situations, rather than just depending upon imaging technologies, I would suggest that looking at the nerve fiber layer, either clinically or by red-free photographs, would be of great benefit in making a diagnosis between glaucoma suspect and early glaucoma. All the 4 diagrams that I've shown you, disc photographs that I've shown you, are variations of physiological cupping, as you can see with the visual fields here. As opposed to that, all these 4 are glaucomatous disc damage with a relatively early damage. In the first example, you can see that though the disc is myopic and tilted, you can make out an inferior nerve fiber layer defect that translates to a superior arcuate scotoma. The inferior notch here Because of the large disc, the cupping may look ominous, but the field damage itself is not very advanced. A small disc, the cupping may not be looking like glaucoma, but you need to pay attention to the neuroretinal rim inferiorly, which is much smaller compared to what you see superiorly, and the nerve fiber layer defect that will translate to established glaucoma. So the point is, in those small discs, we should not miss glaucoma and call them as suspect. So let's look at this case a little carefully. A visual field that is unreliable. There are some points in the inferior hemisphere that satisfy the Anderson's criteria. Only one of the Anderson's criteria is satisfied because the GHT is normal and the pattern standard deviation is also not flagged off. But if you look at the disc and pay attention to the nerve fiber layer, you notice a superior nerve fiber layer defect here. It is in these situations that we'll go with the help imaging technology. The imaging technology does show that there is a superior nerve fiber layer defect and a ganglion cell loss in the left eye, and the rest of the imaging is completely normal. That correlates with what we see clinically. Because of that, even this unreliable field with only one of the three Anderson's criteria satisfied will actually translate to be a glaucomatous early glaucoma and not a suspect. So from that perspective, the advantage of having the red of the imaging technology and the black of visual fields being seen together will show that this is an artifact, the disc is healthy, and the patient does not have preperimetry glaucoma. We should be careful in labeling these as glaucoma and treating them aggressively. As opposed to that, there is a superior nerve fiber layer defect, superior RNFL loss. The red of the imaging technology and the black of the visual field actually correlate with each other. This is a definite early glaucoma. One of the things that we need to remember is the natural course of the disease. Our understanding of the natural course of the disease will translate to how we talk to the patients. So this is one of the best studies that I can quote of 3,790 subjects with a 3-year follow-up that showed that progression worse than minus 1.5 decibels happens only in 3% of the patients on treatment. Statutory blindness of a mean deviation less than 22 decibels happens only in 5%, and visual impairment happens in 1 in 10 people. What is important is that in all these people that progressed significantly, at presentation, the mean defect was worse than minus 6 decibels. And the other important information that you get from this is this graphic. All these blue dots are probably glaucoma suspects that improve over a period of time. The green dots are glaucomas that do not progress rapidly and will not have a visual handicap. The yellow dots will have a visual handicap, and the red dots are the few ones that actually progress on to develop severe visual field loss in glaucoma during their lifetime. It is these patients that we need to be aggressive with, and in these patients we need to be very careful in scaring them to blindness because of the diagnosis that we make. So from that perspective, our inability to examine completely and make a correct diagnosis will result in my flat-footed statement that glaucoma suspect is probably an iatrogenic disease. How does it translate into practice? This large physiological cupping in both eyes was suspected to be having glaucoma. The visual fields were done and they showed a very rapid progression. And because of that rapid progression, the treating physician also wanted to do an MRI. But when we saw him and reassured him because of those large physiological like looking discs and asked him to get back to the visual field machine with more confidence, the visual fields turned out to be almost normal. So I would probably change the topic from when to treat to actually how to manage. Sorry, I missed one slide there. To how to manage glaucoma. And from that perspective, we all need to remember the effect of labeling, that once a suspect, he will be a lifelong suspect. We need to understand and discuss the natural course of the disease. And as I have shown you, a large number of glaucoma suspects may not be having disease and they may actually improve over a period of time. When we label the disease as a preperimetric disease with careful evaluation, that is the time what is necessary would be from treatment point of view, do a diurnal variation of intraocular pressure with a unilateral trial, establish the benefit of therapy, and then start the patient on treatment. Thank you for your attention.
Thank you very much, sir, for that wonderfully informative talk. We'll move on to Professor Das, and then we'll come back to you because we already have questions. Professor Das, you can share your screen, sir.
It's not coming?
No, sir.
Okay, just a few minutes.
Yes, that's perfect.
Can you see now?
Yes, sir. Yes,
Okay.
sir. Perfect. Perfect.
Okay, thank you, Dr. Chandrama, for the opportunity you have given me. And I'll be talking about the secrets of anterior segment glaucoma. There are so many secrets, but I will come to a very simple secret. Practically everybody knows what is happening, but doesn't know how this is happening. But there are two varieties of glaucoma. That one is the anterior segment glaucoma with a high pressure. Other one is the posterior segment glaucoma where the pressure plays a less role. And then maybe a mixed form where the intraocular pressure is raised. At the same time, there are posterior segment components along with it. Just before we really go into the physiology, the pathological part of it, I must remind you about some of the anatomical facts, generalized, that all the aqueous outflow system is a part of the vascular circulatory loop, and the vascular circulatory loop returns the fluid to the heart by some sort of pumping mechanism. That is what is happening in the general body. Applying this to the eye, the Schlemm's canal is communicating directly with the venous system, and the trabecular side of the Schlemm's canal is a highly modified and structurally designed structure to act as a mechanical pump. This is the normal physiological change that has happened. Apart from that, there are some of the very important structural changes in the trabecular meshwork, which has modified the trabecular meshwork completely. The trabecular meshwork is a flexible membrane, and it is a property to expand and recoil back. That is the basis of the physiological part of the whole system. And the Schlemm's canal is lined by a single layer of endothelial cells, which is modified and forms a bundle of cells and line the trabecular meshwork and the juxtacanalicular tissue. The trabecular meshwork functionally is also modified in such a way that it has got a very well regulated information network, and the endothelial lining of the Schlemm's canal is a pressure and flow sensitive area which initiates the process of the pumping characteristics, which then spreads gradually to the trabecular meshwork and juxtacanalicular area. It is stuck up. All right. So what happens in normal condition and in systemic phase of the blood pressure, it's all related to the blood pressure and the eye pressure. In systolic phase of the contraction of the heart, the intraocular pressure rises, aqueous is pumped from the Schlemm's canal to the aqueous veins. In the diastolic phase, the aqueous is pumped from the antechamber to the Schlemm's canal through a series of collectors which are valved. I'll show you how exactly it happens. See, this is happening in the systole, and the fluid is going to the aqueous vein. And then diastolic phase of the cardiac cycle, and it fills up from the antechamber to the Schlemm's canal. That is normally what is happening in our body. There are two pumping mechanisms associated with the systolic and diastolic blood pressure. How does it happen? That is the question. So this is happening because of the endothelial cell function, endothelial lining, which is lining the trabecular meshwork and the Schlemm's canal. That is the center of all activities. And those endothelial cells are pressure sensitive and also shear sensitive, also flow sensitive sensors. They have those sensors which regulate the vessel wall composition. The whole thing starts with the increase in the intraocular pressure due to the ocular pulse. During the systolic and diastolic blood pressure changes, the intraocular pressure also changes. In associated with that, even with the movement of the eye, blinking and the squeezing with the lids will also increase the intraocular pressure. And during the systolic blood pressure, the intraocular pressure rises, endothelial cells lining of the trabecular mesoscleral is stretched and they're pushed outwards towards the Schlemm's canal, and the changes in this vessel composition, it regulates the intrinsic responses of the distension on the and the recoiling. And this is not the intrinsic factor which is regulating the whole pumping mechanism. And the result is the Schlemm's canal space is reduced practically to the potential space, forcing the aqueous into the collector channels and the aqueous fans. The stretching of these cells, they gain certain amount of energy and retains that energy, and which is used to recoil back the trabecular mesoscleral to in the diastolic phase. So in diastolic phase, what happens when the intraocular pressure comes down, the elastic trabecular mesoscleral tissue recoils back to its resting configuration. The trabecular recoiling produces a vacuum in the Schlemm's canal that sucks aqueous into the Schlemm's canal via the aqueous collector valves, which are unidirectional and are pulsatile. The distension and the recoiling of those endothelial cells actually determine how much is the stroke volume, how much the amount of fluid that is discharged from the Schlemm's canal to the subcontinental space. I'll show you again to give the idea that it is happening like this in the systolic phase. And see, this is also filling the Schlemm's canal is filled up, and from the antechamber it is gradually filling to the. So to summarize what is happening, there are two mechanisms at play when this is happening, that the aqueous is pushed from the antechamber to the Schlemm's canal and from the Schlemm's canal to the subcontinental space. There are two mechanisms involved in it. One is the intrinsic mechanism, which is most important regulatory mechanism. It consists of the Schlemm's endothelial lining, trabecular tissue and its lining, and the juxtacanal tissue. This regulates the vascular wall composition that in turn determines the lumen size, the distensibility and the recoiling capacity of the trabecular mesoscleral, and that ultimately decides the stroke volume, the amount of fluid which is displaced from the Schlemm's canal to the subcontinental space. Apart from this intrinsic mechanism, there is an extrinsic mechanism which is also at play in anterior segment glaucomas, that consists of the structures attached to the trabecular mesoscleral. Anteriorly, it is attached to this solvus line, and posterior to the scleral spur and ciliary body. And these three structures also play a very important part in the development of the glaucoma in the anterior segment. And because that they are separate and their control is also neural and hormonal factors, they do not depend on the intrinsic aspects of this pathology. So what happens actually in glaucoma? There is a combined intrinsic and extrinsic changes that results in the anterior segment glaucoma. The trabecular tissue becomes less flexible, loses its ability to stretch and recoil in response to the changes in the intraocular pressure. That changes in the position because of the changes in the extrinsic factor. That means it comes closer to the Schlemm's canal external wall. This progresses till the lumen is practically closed. The stroke volume is reduced. Actually, the pump fails working and pumping it to the subcontinental space, and there is a resistance to the aqueous outflow, and that prevents the aqueous to enter the Schlemm's canal, and ultimately what happens, the intraocular pressure rises. Thank you very much.
Thank you very much, sir. Can you hear me? Thank you very much, sir. That was a really wonderfully illustrated talk, and I'm sure all of us, including the postgraduates, has benefited from that talk. Wonderful. We'll move on to the next keynote speaker, Dr. Harsh Kumar, sir. Sir, you can share your screen.
Thank you, Chandrima, and KAO for having me again in Calcutta, because I am a regular visitor, as she told you, and I love to be there. So I think we'll be speaking about some lasers, but I think a number of topics are being covered in further talks, especially the most important laser, that is laser iridotomy is being covered by Satyan. So I'll just go on to some unusual topics. And so we had a 22-year-old girl who had come to us with healed uveitis, and her other eye was already lost due to surgery related to some things which were done for uveitis and cataract and whatnot. Multiple iridotomies were done which were being failed, and the iris Bombay simply did not get relieved. There was a posterior subcapsular cataract which would, because of the things, the vision was really less, and the patient was in dire straits despite all medical management, and that is how iridolenticular synechiolisis were born. So we thought and what we could do really to relieve this without doing any kind of surgery. So what exactly we did was that stretch out the iris, and on the synechia, just go anterior to the synechia and use minimum energy of the YAG laser, that is 0.5 millijoules of ND YAG laser. And now this synechia hitting more towards the iris than towards the lens was able to be cut in order to be able to make this space free. Obviously, you require multiple sittings. It invariably bleeds from here. So go from inferior to superior to all sides, and gradually you can open it up so that the entire thing is opened up. And we were really lucky that way that the posterior subcapsular cataract was bypassed. The patient was having much better vision, and the aqueous flowed from here. And so later we did some iridoplasty as well to flatten out the periphery, and it really worked wonders for the patient. And that is how this procedure can be used in patients in which iridotomy is repeatedly failing. And this is another thing. When we had a 63-year-old male who was referred to us, trabeculectomy done, and obviously there's a diffuse bleb which is causing not only dysesthesia but hypotony, macular edema, there is a decreased vision, the pressure is low, and all conventional treatment had been tried, and classically he should have been taken up for surgery, but the patient refused. So we thought, let us try something else. So what we did was we painted this area with gentian violet, and then we went ahead and did a laser over there. The spot size was large, as you can see, 300 to 500 microns, and energy was low, 0.2 to 0.3 watts, 0.1 second power with any coagulative laser that you have. Classically, you have the argon laser. You can use the frequency doubled ND YAG, that is the P green laser. And the idea is just to scar out this area. And it really worked wonders for us. As you can see, the whole thing got scarred up, and the bleb was retained in the superior quadrant, and inferiorly it was all healed up. And what was a massive choroidals initially is improved so much, and the vision and all those things really improved. So without taking patient to the OT, one can really work wonders over there. Similarly, if you have an overhanging bleb which is causing a Denon and other problems, you can do sutures, but then again, a simpler thing would be just to paint the bleb and do again similar kind of spots, large spots, low time and low wattage, and what you get is again flattened blebs which can really help things. The other important thing is peripheral iridoplasty and gonioplasty, which I am really surprised a lot of people still do not use regularly. It's a wonderful thing. All you have to do is a large spot size of 300 to 500 microns, low power of around 0.2 to 0.3 watts with 0.1 second. The idea is to char the superficial iris so that the angle opens up. If there is a pigment release, means your energy is more, and increase the power or increase the size of the spot. And it can be done either with the help of a lens, or you can even do it directly. The classical treatment when we use gonioplasty is in cases of plateau iris. You have done a peripheral iridotomy, either with the help of a gonioscopy, you know there's an S-wave sign, or if you have done an iridotomy, you dilate and you see you are still stuck up, and the thing is the iris, last fold of the iris is still covering over here. That is when you actually need to do an gonioplasty. This is peripheral gonioplasty or iridoplasty as we call it. Any coagulative laser can be used. You can have again use argon, even diode can be used. You can use P green 532 nanometer ND-YAG laser. The idea is separate out by one spot size, and you can do it if you're not too experienced. You can always do it with a gonio lens. Just put it 1 millimeter away from the angle and start making the spots, and you can see the retractions right in front of you. So this is the angle which was closed, can open up nicely. You can see it in anterior segment OCT, how widened the angle becomes. But the biggest advantage that I have always seen in this is, like there was a 52-year-old female presented to us with a pressure of 48 millimeters, angle closure glaucoma, acute attack. Whatever we do, the thing was not settling down, and I was really very worried because either we'll have to go in and do a surgical PI, which could be a disaster at such a high pressure not coming down. We may have to do a minor WIT in order to decrease the pressure. And then suddenly I realized that yes, Dr. Lamb had long time ago said that even gonioplasty can work. So we did a gonioplasty, and you can always do it even through this corneal edema, because doing a peripheral iridotomy in this kind of a pupil is almost impossible, because the iris is boggy, there is corneal edema, but the iridoplasty gets through. And you can see within 45 minutes, you can see such a beautiful thing. The pressure is completely settled down, and later we went ahead and did an iridotomy. If I'll tell you that take up one procedure in all acute angle closures, you can do this wonderfully well. Not only this iridoplasty can be done even in cases of angle closure glaucoma block at the lens. Now we know that the lens is to be taken out, but there may be 2-3 days when you can't even do the surgery, and at that time this really helps to lower down the pressure. Same with the situation with topimerate induced angle closure glaucoma, where you know you have stopped the topimerate, things are going to get down to normal, and but obviously you have to wait for some time, and the pressure sometimes may just not come down. Many a times you are even scared of giving Diamox, because you know that even sulfas can result in a situation like this. So here again you can do an iridoplasty which can work wonders. Again, in cases in which you have already done a peripheral iridotomy in chronic angle closure glaucoma, the pressures are borderline high, you don't want to operate, the patient doesn't want to get operated, you should try a peripheral iridoplasty. And if the angles are opening up while you do the peripheral iridoplasty, the pressures can go down by at least 3 to 4 millimeters easily. And I have done, especially if you then do an iridotomy and then you see and you do a gonioscopy and you find that it is still very narrow, it is always helpful to add gonioplasty to these patients. Again, peripheral iridotomy will be covered fully, but I just wanted to say that in case it's a very thick iris, a lot of people keep asking me, what do we have to do? Use pilocarpine. And then what you do is give multiple argon spots in the same way as gonioplasty. That is 300 to 500 microns, 0.1 to 0.2 at low power, and 0.1 second, so that you stretch out the entire iris over here in a drumhead fashion. And then when you give one spot of YAG, high laser YAG, it will just open up beautifully. Again, many times people ask me, sir, the whole of the iris is there, iridotomy, but I want to enlarge it. How much what power should I use? So I tell them, just if you have a YAG, most probably you will have a argon also. So use any coagulative laser, just one spot on either side, 1 or 2 spots on either side, and you can see that it nicely opens up with coagulative laser. ALT is going to be covered. The ALT and SLT, I just wanted to reiterate that the best thing for us to use it is in pregnancy, because no drug is safe in pregnancy. So please remember, if you don't have an SLT, ALT, at least everybody has an argon laser. You can do an ALT, reduce the pressure by almost 6 to 7, even 4 to 5 millimeters easily for some time. That is required in pregnancy. And obviously in malignant glaucoma, you have given atropine, you have given anti-glaucoma medications, things are not working. Please do try a YAG laser, especially if, obviously if it is a pseudophakic, then only you can try. Do an anterior hyalerotomy, break the phase of the YAG with the YAG, and then you can go in and break some pockets as well, and it really works wonders, because short of doing a vitrectomy, this always works and the chamber deepens out. Thank you very much for your kind attention.
Ma'am, you need to unmute.
You are muted. Rama, you are muted.
You were doing it, Chetna. That's what the message came. Anyway, so sir, there are lots of questions, but I'll take one for you, which is directed to you, Dr. GC, sir. It says how to diagnose generalized loss of RNFL clinically.
Generalized loss of RNFL clinically is very difficult. It is only the wedge-shaped defects that we can make out clinically. Generalized loss that is restricted to one hemisphere can be picked up by comparing the image from the other hemisphere. But if there is a diffuse loss of RNFL all over, then it is difficult to diagnose clinically. The point essentially one needs to remember is that in the presence of such a diffuse loss all over, the diagnosis of glaucoma is not in doubt. There will be definite visual field changes and the cupping and other things will be clear cut. My focus was on early diagnosis of glaucoma. So what we need to remember is that in early glaucoma, only one hemisphere is affected. So you will have the other hemisphere for comparison. Whether you're looking at the imaging or you're looking clinically or you're looking at the red-free photographs, when you are suspecting glaucoma, you need to remember that the damage is going to be only in one hemisphere. Which hemisphere am I suspecting the damage? Is the imaging or the red-free photograph showing changes only in that hemisphere and not diffusely? When you see a diffuse RNFL loss, it's more likely to be, especially in the imaging, it's more likely to be an artifact than because of disease. So the most important lesson I think that needs to be taken is that a suspect would have only a one hemisphere damage and you would have the other hemisphere for comparison. If there is a diffuse loss involving all the hemispheres, both the hemispheres, then we are not suspecting glaucoma. It's established.
Thank you. Thank you very much, sir. There's a question Dr. Shumit Chaudhary would ask Professor Das.
Yeah, Professor Das. Good evening, sir. Sir, just one question has come out. At what intraocular pressure should one start a treatment in case of glaucoma suspect, number one? And number two, is there any role for vasodilators as per your talk is concerned?
No, but I don't think there's no role of vasodilators, established role of vasodilators in glaucoma treatment, because you don't have any other treatment available. Out of frustration, sometimes you start giving them the vasodilators, but it has no proved results that vasodilators are likely to increase the blood circulation in the optic nerve. That is one thing. The pressure is actually the target pressure. One has to decide what is the target pressure for this particular patient. It may be as low as 11, 12 or even 9 or below in the single digits, or it may be as high as maybe 27, 28. So that has to be individually decide which pressure is the target pressure for this particular one. So that one has to decide after doing the diurnal variation in some cases.
In many cases, normotestic glaucoma we find is the intraocular pressure after is about as a single digit. Still, there is progression. So, what is the next step should we go?
See, these are really difficult cases to treat, and we do not know whether say calcium channel blockers will help. We do not know whether increasing blood circulation will help, or we take care of the environmental factors. And the blood pressure is certainly the very, very important factor we must look into. The low blood pressure is more harmful than the higher blood pressure. So these are really tricky cases, and sometimes with all the precautions you take, then you really feel frustrated, and that may be amount to very small number of patients, but they're important for that patient, important for us. But sometimes we really raise our hands that we can't do anything for such patients, and because it progresses even in spite of the intraocular pressure coming down to the lower level, single digit level. Sometimes the ginkgo biloba and other things have been tried, but these are all treatment of desperation, not with a definite action on those cases.
Yes, sir.
Well, and next question will be for Dr. Haskumar sir. The next question comes in related to PI or laser. What is your take regarding management of intumescent mature cataracts with appositional angle closures? Do you do any kind of PI or laser trabeculoplasty? Laser iridoplasty for that, or you just go ahead with the cataract surgery?
That's exactly what I was trying to say, that in case, because of certain situation that you cannot take up the patient for surgery immediately, in that situation one would possibly like to do an iridoplasty. Works very well, but I think that is only a very part-time solution. The ultimate thing is that you have to take out the cataract. So it is just a case in case, suppose your OT is not available or certain other things are happening with the patient that you cannot immediately take up the patient. Then in that situation, I would do an iridoplasty and wait so that the pressure comes down. You can give IV mannitol and all that, and keep on all full anti-glaucoma medications. But the ultimate treatment is removal of the lens.
Thank you, sir.
Thank you, sir, very much. We move on to the next presentation. Dr. Mayuri Kamar, you can share your screen, Dr. Mayuri, and start.
Thank you, Chandrima, for giving me this opportunity. Can you see my screen and hear me?
Yes, clearly.
Okay. So the management of advanced POAG, I'm going to share some of the pearls that can be used in the special cases of this. Why they need special attention? Because here the field of vision is severely affected. Patient is symptomatic and they are at high risk. Even Dr. GC in his one of the graphics showed that these patients are at high risk of progression, and that ends to the blindness. And these patients are symptomatic, so they have very high expectation from us. And the margin of play is very low or narrow. And why there are challenges? One is the illute definition. Second is the imaging techniques or the perimetry that we are using for the diagnosis and monitoring of this patient are not giving us much of information. The RNFL that we are doing with the imaging in early phase gives us good indications, but the same technology has a very poor value in the advanced cases of glaucoma because of the floor effect. When you have a perimetry, they just zoom into the area of the remaining vision and try to use the 10-2 strategy, or if it is severely affected field, you can use the size 5 stimulus and the macular program that will generate some of the dots for the future monitoring and progression analysis. Now, there is no standardized definition. Objectively, we can say that it is only the central and temporal island of the vision, or even only just a temporal island. And subjectively, patient's quality of life is at risk due to optic nerve damage in one or in both the eyes. According to the Hurdap's and Anderson classification, if the mean defect is more than -12 dB, or according to the International Disease Classification, if the visual field loss is within 5 degrees of fixation in at least one hemifield, then, and which is consistent with the DIS finding, then this is the case of advanced case of glaucoma. This is the list of the risk factors which leads to the progression in these patients. For me, the high IOP fluctuation and the pseudo-exfoliation are very important cause. And even in the myopic eyes, the progression is faster. But the most important is decreased ocular perfusion pressure. That is very difficult to manage in these cases. We know that there are considerable evidence in the literature, various studies are there that suggest that lowering the intraocular pressure slows down or prevents the glaucoma progression. And even the AGE study has shown that by keeping the pressure low and sustainable low, then we can stop the progression of the disease. These are some of the recommended target pressures, but preferably the target IOP should be less than 12 millimeter of mercury, or according to AIOS guideline, it should be 35 to 40% reduction from the baseline of the intraocular pressure reduction. But IOP lowering alone is not adequate. We know that the IOP fluctuation is one of the independent risk factor, and this is much more high in the advanced cases of glaucoma that has to be control in our treatment modality. Now, monotherapy, it is difficult to achieve target pressure. PG analog is useful in this condition because we want very, very low IOP, less than episcleral venous pressure. That can be done with the PGs, and they are also advantage of having better control over the IOP fluctuations and variations. We need combination therapy in these patients. And with PGs, we can have a carbonic anhydrase inhibitor, which has a preferred as a preferred partner because it improves the microcirculation of optic nerve. Brimonidine is supposed to have a neuroprotection. Maybe that is the reason why I prefer to use it as a third line of treatment. Beta blocker, even I want to use pilocarpine if patient is not under control to their certain target level. Laser trabeculectomy, plastry has a very limited role, but yes, it helps in reducing the diurnal fluctuation. Particularly when you want to postpone the surgery, patient who is not willing to take the risk of the surgery and he is on the maximum tolerated therapy, we can use this SLT in these patients. The trabeculectomy can bring down the pressure to a very low level. It should be enhanced or augmented with the use of mitomycin C. And I always use releasable sutures in these patients, which keeps me a very stable chamber on day one. The tubes, when I have to use it, I use valve, emet glaucoma valve tube rather than using non-valve, because non-valve may have a post-operative severe hypotony and which leads to wipeout in some of these patients. So when you want to use tube, emet is a better option. Now, one has to do frequent counseling of this patient regarding the wipeout, though it is extremely rare, but still we have to counsel them frequently for this, not only to the patient, but to the relatives also. Pre-operatively, I give injection mannitol, and if not possible, then tablet Diamox. Always try to bring down IOP as low as possible. And in anesthesia, one has to remember that we do not have to try to avoid adrenaline in the xylocaine and never give orbital compression. Now, antimetabolites, when are used, should be placed posteriorly over a wider area, and paracentesis is must. It helps us in having a slow decompression of the globe, and also helps in maintaining the chamber throughout the surgery, and post-operatively also, if required, you can use it. Releasable sutures are advisable. One may take pre-placed suture in these patients to avoid the collapsing of the globe. And wound integrity has to be checked after finishing the surgery so that you can have a stable chamber on day one. These patients, monitoring is very difficult. As I said in the beginning, the visual field may, with 10-2, may generate some data for you. And IOP is the only guideline, and they need frequent follow-ups and aggressive management. The vision rehabilitation in the form of low vision aids will always improve the quality of life. One can also add the psychosocial support to this patient. The good news for us is we have better tools which are more sensitive, specific for the detection of the changes, and there are more medical and surgical options are now available. So to conclude, the advanced POAG patients are at high risk for going the blind, so one has to manage them aggressively to protect the remaining vision, identify the risk factors for the progression and titrate the management accordingly. One has to customize the treatment. Medical treatment can be extremely effective only if the IOP reduction is significant as well as sustained. And incision surgery offers better chance in some cases, though there are risks involved. However, medical and laser therapy may be appropriate in some patients, and visual rehabilitation has to be done in this patient to improve overall quality of life. Thank you very much.
Thank you, Dr. Mayuri, for that wonderful talk. As always, we move on to our next speaker, Dr. Shefali Parikh. Please share your screen and start.
Thank you, Dr. Chandrima. Is it visible?
No, it's not. Yeah, now it is. Now it is.
Thank you, Dr. Chandrima, for giving me this opportunity. So I'm going to talk on brand versus generic. And so brand versus generic is an ongoing topic of debate among all the healthcare practitioners since long time. Now in March 2011, this is becoming automatic. It is changing on its own. One sec. So in March 2011, with the expiration of the Pfizer's patent for Xalaton, sparked a particular interest regarding the generic medications. The reason being, it's not changing now. The reason being, just by shifting from brand to generic, a single patient was expected to save $1,300 annually. And if you look at the world market, then just by shifting from brand to the generic, consumers and healthcare industry could save more than $1 trillion in past decade. So in general, generic drug cost 80 to 85% less than the brand name drugs, and this lower cost is very appealing to the patients. Now let us understand why the generics are less costly. Now when the brands are developed, they undergo this rigorous process of preclinical studies, clinical studies, and then they are introduced into the market, and still they have to undergo the post-marketing surveillance. However, the generics can easily skip these two phases. Moreover, they can generics can be easily reverse engineered to the known drug compound, and also they don't have to bear the burden of proving the safety and efficacy of drugs. Therefore, for the generic manufacturers, the cost becomes very, very low. Now, when it comes to the management of a chronic disease like glaucoma, cost is very important issue, especially the countries like in India. And also there are various studies which have shown positive correlation between the lower medication cost and the improved medical adherence. However, the question is there any difference between the brand and generic? So let us understand that. Now, any drug has two ingredients, that is active ingredient and the inactive ingredients. Now, if you look at the properties of the generics, now the generic has to be bioequivalent. That is, their blood levels has to be similar to those of the reference drug. But now for the topical and the local drops, now since their blood plasma level cannot be measured, therefore the bioavailability studies cannot be performed. And for local or the topical drops, that is our eye drops that we are using, bioequivalence is accepted if the drug is in the same solution and contains the same active ingredient concentration as the reference product. However, the catch here is that the inactive gradient can vary. So what are the inactive ingredients? Like these are the preservatives, pH, tonicity adjusters, antioxidants, and buffers. And if you see the commonly used anti-glaucoma medication, if you see the principal active ingredient, their concentration just varies from 0.5 to 2%, and the inactive ingredient varies from 97.5 to 99.5%. That means major bulk of any drug is formed of the inactive ingredients, and for generic, this inactive gradient can vary for FDA approval. That means for chemical equivalence, it's active, only the active ingredient has to be same, not the inactive ingredient which forms the main bulk. And also at no point in time, a chemical equivalent generic has to prove its therapeutic equivalence as well. So the main question arises, whether the generic is as effective and safe as the brand name. So there are a lot of studies which have cautioned against it, and KAO et al. Who have done extensive work in brand versus generic, and they reported that despite the best intention of the FDA, generic versions of the drug are not always identical to their branded counterparts. Also, there are other physical properties of the generics which we should look into, like the drop size, volume, pH, viscosity, hardness of the bottles, and cost. So let us come to the few studies. Now, when the efficacy was compared between the brand and generic, the brand Timolol XC, it showed a mean IOP lowering of additional 1.4 millimeters of mercury compared to the generic equivalent. And the authors concluded that it raises concern as a reduced IOP lowering effect could translate to the progressive visual field loss. Similarly, a study from South India, which was a randomized crossover trial that compared Xelatan versus generic latanoprost, they also concluded that Xelatan had a better IOP control and lesser side effects. From one of the unpublished data from India, courtesy Dr. Rajul Parekh, that studied the effect of switching from the brand to generic after the patient was controlled on Xelatan, they concluded that the mean IOP increased by 1.8 millimeters of mercury at the end of 3 months when the subjects were on generic. Now, when the active ingredient is compared between the brand and generic, so KAO et al., they reported that the two generic formulations of latanoprost contain baseline level of active ingredients that were 10% greater than the labeled value. That means what is labeled on the bottle is different than what is actually inside the bottle. And also there is a loss of active ingredient concentration after exposure to temperature at 25 to 50 degrees centigrades for 30 days or more. Also, there are other factors like if the particulate contamination was compared between the brand and generic, it all reported that the bottles of both generic medication had higher levels of particulate matter at any point in time. One of the study compared the brand Predfort versus the generic, and they reported that the generic Predfort had greater propensity to agglomerate, and also maybe because of the larger size of their particles, they clog the tip of the medication bottle and therefore affect its concentration once it is instilled into the eye. Now, similarly, if you look at the preservative, the preservatives was compared between brand and generic, and one of the brand name formulation of timolol gel forming solution in the preservative, that is Gallon gum, which lowered more pressure compared to its generic counterpart, where the preservative was xanthan gum. Similarly, the potency was compared, and they found that like 20% of the generic ciprofloxacin eye drops had lower potency, and they underscored, and therefore they affect the outcome. There are a number of other factors which we must look into. When the innovator, they develop the drugs, they don't only develop drug, but also they check the compatibility of the bottle. However, the generic versions, they do not require to check or to look for the compatibility. Also, there is a lot of variation in the shape and size when the generics are manufactured, which creates a lot of confusion within the patients. And also, KAO et al., they reported the variation in the drop size up to 300%. That means in the generic, if there is a large drop size is instilled into the eye, that may affect the cost. And also the generic bottles, which over a period of time, the size of the tip of the hole, it becomes large, leading to ultimately more spillage, and therefore it affects the cost of the drug. So these are the important considerations like bottle material, shape, size, cap color, and diameter of the drop, which are usually overlooked because mainly the focus is on trying to prove bioequivalence of the drug. So just to summarize, definitely because of the cost, generic has an edge, they have advantage. However, we must remember that there are now good companies generics which actually the cost is more or less at par with the other brand drugs. And if it has one advantage, then a number of other disadvantages, like there is a loss of active ingredients at high temperature, there is a high particulate contamination, variation in the bottle shape, size, and also variation in the drop size. On the other hand, if you see the brand, there's efficacy is more and strict quality control is maintained, and there is a less variation in the drop size and concentration. So to conclude, definitely at this point of time, generics, they are here to stay in our Indian market because of their cost. They have a definite role in the glaucoma management, because in our country where there's a patient has to make a choice between the cost of the basic necessities of life versus the cost of this anti-glaucoma or the costly anti-glaucoma medications. However, one has to balance cost, efficacy, availability of drugs, clinical judgment, and we have to factorize the patient's views as well, and then consider their use in his or her practice setting. Thank you.
Thank you very much, Dr. Shefali. That was indeed a very informative talk. And with that, we move on to the next speaker, Dr. Vyas. Dr. Vyas, you can share your screen and start talking, sir.
Okay. Good evening, and thanks Chandrima, Surajit, Sumit, and Kolkata Academy of Ophthalmology for having given me this opportunity. So at last, there is some excitement in the medical management of glaucoma. This is the history of medical management of glaucoma. It goes way back around 150 years before when the pilocarpine was introduced, and then there was a huge lull. And in 1975, the beta blocker, that's the gold standard, timolol maleate, was introduced. And then again, there was a lull of around 20 years or so. And then the new gold standard, that's the PG analog, was introduced. And subsequently, again, there was no new addition of new molecules for almost 20 years. And now again, we have some excitement in the medical management of glaucoma. So the new drops includes the new molecules and the new combinations. And they are all new. There is a novel mechanism of actions. There is additional beneficial effects. And obviously, all these molecules and combination, they are non-inferior to beta blockers. That is a new criteria by the US FDA, that the new drugs which is introduced should be non-inferior to the beta blocker. So out of these, the first one is the latanoprostene binod. It is almost like the PG analog, what we have, but with some additional mechanism. There is another molecule which they have called binod, and that is basically a butanediol mononitrate. And what is the property of this? It liberates the nitric oxide. So because of the liberation of the nitric oxide, there is a relaxation of the trabecular meshwork. All of us knows that what is the mechanism of action of the PG analog. The PG analog enhances the aqueous aggression through the non-conventional pathway. But because of the release of this nitric oxide, there is the aggression of the aqueous through the trabecular meshwork as well. So there is an additional reduction of the IOP with this latanoprostene binod. The latanoprostene binod is recently approved by the US FDA, and it reduces the intraocular pressure by almost 7.5 to 9 millimeter of mercury from the baseline. That translates into almost 30 to 35% from the baseline. The additional reduction because of this is around 1.2 millimeter of mercury to 2 millimeter of mercury. That is the advantage of this latanoprostene binod over the conventional PG analog. There is one more advantage, but that's a theoretical. Because of the release of this nitric oxide, there might be some amount of neuroprotection if clinically it is proven. The another exciting molecule is a Rho kinase inhibitor. The ROCK is the enzyme, that is the ROCK enzyme, that is present throughout the body in almost every tissue. And so is it is in the eye as well. That is present around the trabecular meshwork, in the trabecular meshwork, around the ciliary body, and so on and so forth. And because of its action over there, it is capable of reducing the intraocular pressure. And it has three different mechanisms. The first and the most important is the relaxation of the actin-myosin junction in the peritrabecular extracellular matrix. And because of this relaxation, it dilates the trabecular meshwork, relaxes the trabecular meshwork. So there is a enhanced aqueous aggression through the trabecular meshwork. There is another mechanism of it. There is another enzyme available that is called as a norepinephrine transporter, and it has the ability to inhibit this enzyme as well. And because of the inhibition of the norepinephrine transporter, it decreases the aqueous production. So this dual mechanism is there. Number one, it enhances the aqueous aggression, and number two, it decreases the aqueous production as well. Simultaneously, because it's one of the potent vasodilator, so through this mechanism, it dilates the episcleral veins, and because of the dilatation of these episcleral veins, it enhances the aqueous aggregation to some more extent, and it reduces the intraocular pressure. So the most common ROCK inhibitor is the Ropresa. Obviously, as I said, that the most common, so there has one more, I would be discussing it. And that is what all these three mechanisms are there. And it's recently approved by the US FDA. It is capable of reducing the intraocular pressure by around 5 to 6 millimeter of mercury from the baseline. And the dose of the Ropresa or the nitarsodil is once a day. It's given preferably in the morning hours. There is another molecule which is present in the Japanese market almost like for last 5 to 6 years. It is same like the PG analog. When the Japanese market, in Japanese market, they introduced the uniproston, and subsequently in the US market, the letrozole was introduced, and the letrozole was considered to be much superior, and that's why uniproston was not become popular. Similarly, the ripasudil is there in the Japanese market for almost 5 to 6 years to treat or to reduce the intraocular pressure, but because of its poor efficacy.
Is there a problem? Okay. Shubhida, you can ask your question, which is directed to Dr. Shefali. Dr. Shobhit Chaudhary, are you here? There's a question for Dr. Shefali. Are you here?
Shefali?
She's not here. So Dr. Mayuri is here. You can ask her.
That's one question for ma'am. Yes, see, there's an advanced stage. You use the releasable suture. It's fantastic too. But can I give a tight suture and make the anterior chamber stable, and later go for the laser?
I may not suggest that. Laser needs a special lens for the suture cutting. You have to have an argon laser. But releasable suture is a very simple technique. Just take a one suture. It is very tightly taken, and then you have to just pull it out. So you can titrate even on day 2, day 3. If you have a thick thinner, it is impossible many times to cut those sutures. And sometimes if it is not properly positioned, you may have a fistula formation in the conjunctiva, leaky wound. That is another disaster. So I prefer to have releasable suture in all my patients.
Once
you can titrate the pressure post-operatively.
Once I faced this problem with advanced stage after releasing the advanced stage of cap, after releasing the suture, that chamber flattened and it cannot be recovered. So I have to again open the wound and close it again.
See, you have
what was the fault in mine? I don't know. It was a very tight pulling of the suture or something else.
No. What we can do, we are taking side sutures 2, 3, 4. See, before closing the conjunctiva, I always titrate my wound with one releasable suture and multiple according to my requirement, and then I inject from the paracentesis opening, the BSS, and I find out how much is the aggression. If it is too much, then take extra suture. If it is enough, just adequate, just leave it like that. So many people are taking only, like Satyan is here, he is taking only one releasable suture and he removes it. So it is how much tight chamber you want. And
can I answer one thing in this piece?
Yes.
Okay, that's so Dr. Sumit, what I would suggest, what in advanced glaucoma scenarios, releasable sutures are a boon. And if you have a shallow AC, the thing which may have gone wrong is to never have, again, I would, what I have been doing is minimal 2 releasables always, because you have a safety net. Okay, so because if you have one, then one is all in all. And you have 2 releasables and give at least 2 more fixed sutures. And when you give the sutures, as Dr. Mayuri said, at the end of the surgery, titrate from the side port and just ensure that the bleb is forming. And even before, when you do the scleral suturing, titrate at that time. That is even more better because you will know exactly how much aqueous will come out afterwards. That is just an extrapolation. And at that time, you can decide whether to tighten your suture releasable more or not tighten releasable, put more releasables. Usually 2 are sufficient. Never had a shallow AC in my life because I've been using 2 releasables and I've been titrating both at the end of scleral suturing and at the end when you finally do the conjunctival suturing.
Okay, as far as Dr. Mayuri has said, what success, He's a very aggressive surgeon. I know that. And he's also a lucky surgeon to go ahead with the one releasable suture and in these kinds of cases. Okay. The
I
next
also
question.
hope for two. Is Dr. Vyas back? Okay, so I think in the interest of time, we'll move on to Dr. S.S. Pandav and we'll take him once his connection is fine. So, Dr. Pandav, yeah, please go ahead. Share your screen. And
share my screen.
Yes.
I hope there's no glitches.
I hope so too. Fingers crossed.
All right. Can you see my screen?
Yes, sir. Perfect.
Great. Now, I'll go to the presentation mode. Yeah. Can you see this?
Yes, sir. Perfect.
Okay, great. Good evening, everybody. And thank you, Chandrima, for the invitation to share some of these things, the academic things with
hello
everybody. Looks like Pradeep Vyas is trying to connect.
No, actually, there is a very heavy rain outside, so there was a power cut down and I lost the connection, and I was trying to connect through the hotspot.
Right. So Pradeep, I am doing my presentation now.
Yeah. Please go ahead. I don't know where I was lost, but you won't believe that there was almost 16 inches rain in last 12 hours in Indore.
Really?
Dr. Pradeep, you were at row presser. You were talking about row presser when the connection got lost.
Okay. Anyway, let Dr. Pandav continue. And row presser, anyway, Dr. Kirti, you are going to talk.
Yeah, I'll be covering that actually, yes.
No.
Okay, so I'll continue with or...
Yeah, please go ahead.
I'll continue, right? So basically in glaucoma, what we are looking at is a sustained IOP lowering. And ideally, in an ideal situation, we should have, drug which gives you one dose. And, the application should be sufficient to control intraocular pressure, say for 3 to 6 months, and ideally for about 6 months. And there's a time when we usually call our patients for follow-up. And at that time, if everything is good, we can just give another dose, or if something is not good, then we can make some alterations. So the number of delivery systems are available basically, but there are different ways of dealing with the situation. None of them is perfect, but we do try to increase the contact time, increasing penetration and retention, use many devices like contact lenses, plugs, inserts, injectables. And now we are kind of moving towards injectable and surgical implants gradually with the hope that we can give a more sustained delivery. In addition, we also have, sometimes putting drugs is also difficult. So there are systems which are easy to administer drugs, and they can give you more precise dosing, like a microdosing sprays. And we also have nanoparticle formulations which are under investigation, where the drug penetrates deeper, and can remain there for a longer time. And liposomal preparations have been tried, is available for other systemic therapy, but not for eye therapy so far. What has been of interest is plugs, lacrimal plugs, and they have been in use actually. So any plug which when you use a punctal plug, it will increase the contact time of the drug. But nowadays what is being done is that these punctal plugs can also carry the drug themselves, so they are reservoirs of the drug. And so they can not only increase the contact time, but they also release the drug gradually over a period of time, and they can be retained for a couple of months altogether. And we have some of them commercially available, containing travoprost, that is OTXTP. There's kind of was the name given to it, and also Evolute, which contains latanoprost. And they have a good retention time, retention rate about more than 90%, and IOP lowering about over 23%, which is quite reasonable, and they can give you sustained IOP lowering. Then we also have drug-eluting contact lenses. In fact, they have been there for a long time under investigation, but somehow they have not become popular because they're kind of a marketing as well as logistics issues with these contact lenses. But they are still there, somewhere in place. So what has been, taking more attention recently is the inserts. So inserts are not new. In fact, they have been there for some time in the form of pilocarp inserts or ocuserts, and also with timolol, but they didn't become popular because they would pop out of the eye or they will cause local reaction. But now we have a bimatoprost inserts, which is like a ring-like insert, and it carries, it kind of fits into the, it's supported by both the superior and the inferior fornices, and its retention rates are high and also gives you a sustained delivery of bimatoprost. Now, if you look at the data from these, this insert, if you look at the day 0 is like a pre-treatment IOPN, which is clearly high, 23 to 25 millimeters of mercury range. And also, as the insert, after the insert, it goes significantly down at 2 weeks. You can see there's a marked reduction in, significant reduction in IOP. The line with the yellow triangle is actually a control, which is with the timolol BID. And over a period of 6 months, there's a sustained lowering of IOP using these inserts. However, if you compare it with timolol, there's a little, little reduction in the IOP as you go from 6 weeks to 6 months. So that means that there is a little loss of efficacy if you have a bimatoprost, which is sustained release in the eye. So that is kind of a little unexpected. Another thing which has been gaining attention is intracameral depot, injection of intracameral depot, drugs. And here we also have bimatoprost as well as travoprost is actually commercially is available, is undergoing trials, but these are actually is in restricted clinical use now. You have a bimatoprost SR, which could reduce IOP at 12 weeks to over 30%. And similarly, you have a travoprost, which has been shown to be effective for over 6 months after single injection, and that's EV515, and is available. It will be marketed as an iDose travoprost implant. So these are kind of implants which can be injected into the anterior chamber. So these injectables, they come with their own injection system. You have a very fine needle which carries the drug in its lumen, and this can be done under topical anesthesia in the minor OR or even in the OPD. And once you have injected into the anterior chamber, it stays there in the inferior angle, and gradually it will get absorbed in a period of, say, 6-7 months, and the efficacy will also last that long. So you don't have to basically put drops every day if someone is, was controlled with one of these prostaglandins, adequately. So the daily dosing is not required. However, again, if you look at the data, this is from the animal experiments, I think rabbit eyes. So if you look at the pre-treatment, here this was with the bimatoprost insert, and if you look at the different doses were actually tried, 6 micrograms to 20 micrograms. There's the dose that was given, a sustained release dose, and there was also, for comparison, there's the topical bimatoprost was used 0.03%, like we used clinically in the other eye. The other eye was a control eye. Now, if you say initially in the beginning, there's a kind of a dose response. The response is related to the dose dependent, like higher the dose, more is the IOP lowering. But in about 4 weeks time, that difference tends to kind of disappear, and within 4 to 6 weeks, there's not much of a difference whether it is a 6 micrograms or is it 20 micrograms implant. And but however, if you note, like if you go beyond 12 weeks to 26 weeks, you can see there's actually loss of efficacy even in this as compared to the topical. So the pulsed therapy, it looks like, still gives you more sustained IOP lowering over a period of time as compared to continuous therapy. So this is a bit kind of surprising, and so we need to watch for it. And if there's a loss of efficacy, these eyes may need additional therapy to control intraocular pressure. The other thing would be surgical implants. Now these are kind of micro-electromechanical systems. They are also under development. So what happens here is you have a device which has electronic components and also has a reservoir for the drug, and this can be programmed to release drug at certain times of the day and in certain quantity, and this could be a continuous release or it could be a pulse therapy. So that's the advantage here, that it could be a pulse therapy can still be maintained in certain situation if that seems to be better, like we have just seen in the prostaglandin analog examples. But the disadvantage is that this is a surgical procedure and you have to implant like a glaucoma device. It needs to be implanted surgically in the vicinity of the globe somewhere. But the good thing is that you can administer medicine the way you want, and also you can recharge periodically depending on the the drug you are using. However, there are a number of things available, but again, at the end of the day, it is the patient's preference which is important. Now, most of these therapies are still at different stages of development. Some I have made to the clinical trials, but they're not, kind of available for general or common use. But if so, we don't know whether the patient are going to take them or not. So this was a survey, is a patient survey basically. It's not the actual study where the drugs were given, but patients were asked for their preference, and they were asked whether they want drops or they want the micro pulse system, or they want a drug-eluting device, contact lens or a ring, or an injectable subclinical injection or an anterior chamber injection. So they were asked for their preferences, and by and large, people would prefer eye drops still by overwhelming majorities. And that is true for glaucoma of different severity, as well as patients who had undergone incisional surgery earlier before glaucoma and they still need medicine. So the preference still remains the drops. Now the reason for this could be because the familiarity. People are familiar with the drops, they are used to it, and they feel more comfortable using eye drops, whereas any experimental therapy would have some resistance. But I'm sure as the things develop further, once these things come into common practice and we see the advantages, these preferences are likely to change over a period of time. So to summarize, better drug delivery systems are under investigations, and some of them are likely to come to the market. They can make glaucoma management more effective and convenient to the patients. Sustained release methods are already in practice. Many new drugs targeting these newer pathways are also becoming available, like Dr. Pati was actually talking about some newer kits, and those newer drugs may actually need newer methods of delivery as well. So this area looks hot and exciting for for drug development, and we look forward to seeing more action in this area. Thank you very much, and once again, thank you, Chandrima, for this opportunity.
Thank you very much, sir. Thank you very much for your wonderful talk. And I was just wondering, hearing your talk, that when we are going to be able to use all those wonderful drugs for our patients. Thank you very much. And we move on. We go back to Dr. Vyas, actually. Dr. Vyas, are you ready? Yes, yeah, there you are. You're smiling.
I'm on the hot spot now.
Yes. Okay.
Okay. So just not to lose the momentum, I will start with this. We have some new molecules, we have some new combinations available, and it's all novel mechanism. And I was talking about the latanoprostene B0. It is very similar to the PG analog, except that it's a nitric oxide releasing compound. And because it's a nitric oxide releasing compound, it has some additional reduction in the IOP because it relaxes the trabecular meshwork. So through conventional and through non-conventional pathway, it enhances the aggregation of the aqueous, and apart from that, it might be a neuroprotective as well. Rho kinase inhibitor, I'm sure that Dr. Kirti would be talking, but what I was talking of, the three mechanisms of action. Number one, it releases the actinomyosin junction at the peritrabecular area, extracellular matrix, and because of that, there is a dilatation of the trabecular meshwork, and it enhances the aqueous aggregation. And number two, there is another enzyme called norepinephrine transporter. So it causes the aqueous secretion, and once it inhibits this enzyme, there is a decrease in the aqueous production. So it enhances the aqueous aggregation both through the trabecular meshwork as well as because of the decrease in the epicellular venous pressure. It is a very potent vasodilator. And also it reduces the intraocular pressure because of the decreased aqueous production. So it has a triple mechanism of action. One is this and two is this. Okay. And it reduces the intraocular pressure by almost 5 to 6 millimeter of mercury. It's given once a day. And the brand name is Ropresa. It's recently approved by the US FDA, maybe about 1 to 1.5 years before. But 5 years before, another molecule of the same family is the Ripasudil. It comes in a 0.4% concentration, was there in the Japanese market to treat the glaucoma, to reduce the intraocular pressure. But obviously the Ripasudil is used twice in a day, has a lesser efficacy as compared to Nitarsudil. And you know, if you want me to say that, I would tell you that it can be compared with same as the Uniprostan and the Xenatan. The Uniprostan was launched in the Japanese market, but it was not as potent as the Latanoprost. And the same way is the Ripasudil is not as potent as the Nitarsudil. Okay, so there are lots of side effects of the Rho kinase inhibitor as well. As I said, it is a potent vasodilator. So it causes a hyperemia in almost 30% of the patient, causes lots of burning and irritation. Aid-on medication also, it can be used as an aid-on medication, and it reduces the additional 2 to 4 millimeter of mercury intraocular pressure. And as I said earlier, Nitarsudil is more potent as compared to the Ripasudil. As far as the safety in pediatric patient, pregnant and lactating women, it's not defined. But safely it can be used more than in 18 years of age patient. There are lots of additional benefits of this molecule. Number one, it preserves the corneal endothelium. There are anecdotes available, but we are waiting for some more scientific evidences. And because it's a potent vasodilator, so probably because it enhances the capability of the oxygen carrying capacity of the blood, so it can be protective for the diabetic retinopathy and related macular edema. And the newer combination is a Roclatan. It's the most exciting anti-glaucoma drug, which I feel so. Is a beta blocker free combination. It's a combination of Xelatan and the Nitarsudil, that is the Ropresa. Supposed to be the most potent, and it reduces around 2 to 4 millimeter of mercury additional intraocular pressure as compared to Xelatan alone. And it's used once in a day. So I personally feel that, you know, one is the Roclatan, other is the Vyzulta, and third is the Ropresa, are very exciting molecules. So after almost a lull of 20 years, we have some new drops available in our armamentarium to treat the glaucoma. 2 new molecules are available, and both have a novel mechanism of action. Latanoprostin do not considered to be superior to the PG analog because it has a nitric oxide releasing property. And the ROCK inhibitor are all new and promises a big potential. Dr. Kirti would be talking on that. And the Roclatan is a new beta blocker free combination, and it looks very, very exciting. Thank you very much, and thank you, Chandrima, once again for your kind invitation.
Thank you, sir, very much. That was indeed a wonderful talk, and you did enlighten us a lot regarding the drugs. So with that, we move on to our next speaker, Dr. Ronnie George. Yeah, Dr. Ronnie, you can share your screen and start.
Dr. Chandrima. Can you see my slides?
Yes.
So thank you, Dr. Chandrima and the Calcutta Academy for the invitation. So I'm going to speak briefly on nocturnal intraocular pressure in glaucoma management. So I'm going to talk a little bit about IOP fluctuations at night, how it impacts the optic nerve, the other nocturnal factors that can play a role, and the effect of medications. So if you look at intraocular pressure measured through the day in the habitual position, so during the daytime sitting and at night supine, this is what you see. The lower 2 graphs lines show you what happens in people who are young and old, but normal otherwise. And you can see a distinct spike in the night. In glaucoma, the same spike is seen in these people too. And most of these spikes actually occur at times when we don't really monitor the intraocular pressures. But if you measure the IOP supine consistently, you find that the intraocular pressures are higher than what you record sitting. So it's a supine position more than the sleep which creates a problem. So the supine position causes elevation of intraocular pressure significantly more than what happens when you're sitting, irrespective of the time of the day or night. But there are other issues too, because aqueous humor during sleep actually production decreases. So why does the intraocular pressure rise? And this has been nicely illustrated in this study on the aqueous humor dynamics in young healthy adults. You can see what happens to aqueous flow rates in day versus compared to night. You can see the flow rates actually come down. And this is supposed to be attributed to increased epistylial venous pressure, which may cause an increased intraocular pressure. And that's why you may see a spike on waking also. But this is difficult to really measure exactly because of the lack of equipment. The other factor that we need to take into consideration is blood pressure at night. In 10 to 20% of normals, and in most hypertensives, you see a drop in blood pressure at night. And these are called physiological dippers. And when you look at this has an impact on the ocular perfusion pressure, which is affected both by arterial pressure and your intraocular pressure. So the concerns that we have from the glaucoma point of view is an increased IOP at night because of these reasons. And we have to also take into account nocturnal hypotension in some normals and in significant number of hypertensives. And when you looked at this study, which looked at nocturnal blood pressure and glaucoma progression in patients with NTG and open-angle glaucoma who are classified as dippers or non-dippers, you find that those people whose blood pressures dip significantly at night were much more likely to progress as compared to non-dippers. So the issues for glaucoma are twofold. In terms of the hypertensives with glaucoma, we need to avoid night dose of antihypertensive drugs. In terms of the intraocular pressure at night becoming a problem in people, we need to control intraocular pressure adequately at night. Among the drugs available to us, there is this elegant review published earlier this year, which looked at all the 24-hour studies for the different drugs. And you can see that there were 2 studies on alpha agonists. None of them showed significant reductions in nocturnal IOP. With beta blockers, 1 of the 5 studies showed a significant reduction. With carbonic anhydrase inhibitors, 1 of the 2 studies. And with prostaglandins, almost all studies showed a significant reduction of intraocular pressure at night. And when you look at this graph, it basically shows you 4 drugs. The baseline is the baseline intraocular pressure, then timolol, dorzolamide, and latanoprost, and what happens over a 24-hour period. So the shaded area is the night time. And you can see here that with timolol, you don't really see very much of a change at night. With dorzolamide, you definitely see more of a drop at night as compared to timolol and as compared to baseline. And with latanoprost, you see the largest drop. And it is not only latanoprost, but all prostaglandins produce significant intraocular pressure lowering at night in addition to the daytime. And this study done by Kaveh Mansouri's group, where they actually looked at a 24-hour pressure contact lens sensor. So the yellow line shows you what happened to the intraocular, the blue line shows you what happened to patients who are on either beta blockers or alpha agonists or carbonic anhydrase inhibitors. And the yellow line shows you what happened in patients on prostaglandins. And you can see that patients on prostaglandins, you don't see that spike at night that you saw with all the other 3 classes of medications. So even with the 24-hour intraocular pressure monitoring, the prostaglandins were the only group of drugs which seem to significantly impact IOP at night. But keep in mind that while the prostaglandin analogs produce very good intraocular pressure reductions during the day, the reductions at night are more modest, but they still do cause reductions. Beta blockers have little or no effect. Alpha agonists again have little or no effect at night. And topical carbonic anhydrase inhibitors probably some modest efficacy in reducing intraocular pressures at night. What about combination drugs? When you combine an alpha agonist and a carbonic anhydrase inhibitor, you do seem to see reductions in nocturnal IOP also. When you combine beta blockers and carbonic anhydrase inhibitors, again you see reduced intraocular pressure at night in about half the studies. Prostaglandins, there's only 1 study, and that also showed combined with timolol, there's 1 study which showed a good reduction of both the combination as well as the prostaglandins alone. What about surgery? If you're looking at surgery, surgery produces excellent 24-hour intraocular pressure controls. You do not see those spikes that you see otherwise at night. So in summary, consider nocturnal intraocular pressure and blood pressure changes as an additional risk factor for damage. Consider 24-hour facing when you're having a patient progressing without a cause. Avoid night doses of antihypertensive drugs if you can. Use drugs or combinations that reduce IOP at night in people who tend to progress, and consider surgery because that actually takes care of both your issues. Thank you.
Thank you very much, Dr. Ronnie. That indeed was a really informative talk, and we all need to keep that in mind when we're actually doing medical management in glaucoma. Thank you very much. And with that, we move on to Dr. Satyan, who's going to speak to us. You can share your screen on laser PI. Dr. Satyan, you can share your screen.
Yeah. Thanks, Dr. Chandrima. I'm Dr. Satyan. I'm going to discuss some practical points in how to do the YAG laser peripheral iodotomy. I'm not going to discuss much about the indications because we all know that the indication for YAG PI is primary angle closure glaucoma and also the secondary angle closure glaucoma with the pupillary block mechanisms. We need to discuss the benefits with the patient. Its the main benefit is going to be the reducing the risk of acute angle closure disease, and also it may reduce the risk of chronic angle closure glaucoma, but the evidence is very scarce. And the future of development of glaucoma and the therapy needs to be discussed with the patient. Sometimes the patient may think that doing the PA itself is enough for his disease. So the safety and precautions as a photo disruptor, when we do the YAG PI, you may come across with a more bleeding, especially in patients with the bleeding disorders, and also those who are on anticoagulants. So this needs to be discussed and addressed. The consent has to be taken properly, and you have to explain the patients about the possible intraocular pressure spikes and the visual dysphotopsias, and there's a very less chance of corneal damage, but we have to just discuss and write it down properly in the consent form. So the pre-procedure preparations are, you have to apply the pilocarpine once or twice, either half an hour or 1 hour before the laser procedure. This is just
Yeah, has it disconnected? Oh, there he is, yeah.
Is that? Sir, I think you can continue, please.
Yeah, you can continue, yeah.
And now my screen got disconnected. Okay. So can you see my screen now?
Yes, yes, yes.
Okay.
Yeah. Fine.
Okay. So the constitution of the people, you can expect it to be around 1 or 1.5 approximately. But when you are using the pilocarpine, what you need to understand is the patients may have the visual blur post-laser and also the headache or the brow ache. So you just have to do the proper counseling, and probably some patients may require a paracetamol tablets once they feel the headache is more. If you feel that the pilocarpine, you don't want to use it, you can use the other alternative method is, if you have the good grips, you can see, you just have to put the bright light in the lasering eye, and also in the other eye, you can just show the consensual, the bright light in the other eye, you can see how good is the pupillary constriction. This is more than enough. You show the bright light in the eye which you're going to do the laser, and bright light in the other eye. With the consensual effect, the people usually stays in that 1 or 1.5 mm. That's good enough for you to do the laser. So there's the other alternative if you don't want to use the pilocarpine. Most of the time I try to do that if you have a good grip. So the preparations, again, the machine really matters, which machine you use and how much is the energy and other deliverables that you have to use it. So I'm going to just talk on the Apasami YAG laser machine. This is a combo machine, and then you can just see the box below. I'm just going to show you the small video clip here. So this is the on-off switch. The equipment is on, and that is the next button is the stick lamp illumination. You just have to increase the brightness when you are doing the PA so the pupillary constriction is well maintained. and you have the laser on off. You can see the laser on off key is there, but don't switch on the laser till you do the procedure. So, and you have the, you can reset the number of shots. Then you have the joystick or the foot pedal for the trigger to shoot the laser. So this is the equipment. And if you are going to use the combo machine, then you can understand that there is a SLT mode and the YAG mode. Just push it to the YAG mode, and then you can do the procedure. And then you have the attenuator. The attenuator is nothing but how you can increase the power. You can see the right side, there is a knob. You just have to rotate the knob to set the power. Usually about 1 or 2 millijoules is more than enough in this machine. So you can just adjust that and keep it at 2. Most of the patients you can do it with the 2 itself. And then there's another one is the aiming beam and the focusing beam. You just have to focus the 2 beams into single, but don't keep the brightness too much, just keep it adequate so that you can focus it properly. Just focus it on the iris clips. So that's going to be the key. Make it as a single point and then just shoot it. And always better to use the lens that's called as the Abraham lens, which is about a 68 diopter lens, which magnifies and also gives a good control over the eye movements. And also you have a very sharp focused laser beam when you use the lens. So this is how you use the lens. It is something similar to the gonio. Just have the patient to look up and then just insert the lens. That gives you a good control and also very easy to do the laser. So before you do the laser procedure, you just need to identify the crypts, like what I have shown in the arrow marks is the crypts. You have to identify, and this is the positioning that is between the collarette and the peripheral iris. So this is the ideal position that you can look at for doing the PI. And the location of the PI, you can do it in any of the positions. The traditional teaching is do it in the superior 11 o'clock or 1 o'clock area, but then if you can do it in other areas also no problem, as long as if you don't do bigger size. So this is the size really matters a lot. If you have about 50 to 100 microns, it is more than enough. There is no need to do bigger like this. No need to do all these sizes. So what is the end point when you're doing the procedure is, so just focus the laser beam and then you try to look at the gush of the aqueous. Don't try to do multiple shots and don't make the iris to bleed. And so this is good enough. If you do multiple shots, then you may expect the inflammation to be more. So post-laser medications, you can use steroids, but a lot of people prefer to use it for 5 to 7 days. Some people prefer to use it as a tapering dose for 10 days. And for the post-laser IOP spikes, either you can use acetazolamide or you can use a timolol if you don't prefer to use the acetazolamide. And the post-laser expectation is you have to just measure the intraocular pressure at the end of half an hour or 1 hour and 1 day, and you can just do the follow-up from there on. And you look at the patency of the iridotomy and also see the gonioscopy to assess how much of the angle opening has happened. The complications, the intra-laser complications is more often we see the microhypemas and the corneal burns, very less incidence. And also the blurred vision is quite often seen because of the pilocarpine therapy, or the number of shots which you have used is more, so it causes more inflammatory response. Post-laser, you can expect a little bit of glare and shadow and diplopia, but not very common to see. There's an increase in intraocular pressure that can be addressed appropriately depending upon the disease status. So visual dysphotopsias, especially when you do the PA temporally, have been the reports have been less visual symptoms in comparison to the superior laser peripheral iridotomies. If you're planning for a cataract surgery, please do watch out for the small people with the posterior synechiae and also the subluxation of the lens. If you have a very large PA, probably when you're doing the laser, you would have just ruptured the zonules. So I've given you some practical tips. Thanks for watching. Thank you.
Thank you very much. Thank you very much, Dr. Satyan. And there is a question for you. I think we'll take that one question. Dr. Shumit Chaudhary, could you please, are you here? Dr.
Yeah.
Shumit Chaudhary? Yeah.
Just one question for
Dr. Satyan. Yeah.
Hello, Dr. Satyan.
Yeah,
that come question for you. Just If the patient is on aspirin or other blood thinning agent, should we defer the PI or we can continue with the PI? Number one. Or next question, the status, some papers are already coming. After doing a normal PI, there is a loss of endothelial, loss of the cornea. Can we go for the specular microscopy before doing the PI in very shallow anterior chamber? Because there is a corneal burn, it may go for the PI in the very shallow anterior chamber.
Okay, just let me address your first question first. The first question is on the ecosprin or anticoagulants. It is kind of a controversial now that even if you stop, whether you are having a benefit out of it is a controversial thing, but in person, when you're taking the consent, it is better we ask the physician whether we can stop that. Now the cataract surgery, we don't really stop it. But the laser, I do stop it because we have come across quite a few patients with though we see microhypema, but if you see an hour later, probably patients may have a hyphemas. And 8-ball hyphema is also quite possible, but you have to just make sure that the patient is, ecosprin is to an extent okay, but the clopidogrel and also the warfarin is much more dangerous. So these two group of patients and also those with the liver disorders, especially with the factor 8 or the other factors deficiencies, they might have more problems. So when you're taking the consent, we have to explain and make sure that the systemic diseases have been addressed. So that is one thing. And the second point is on the corneal laser burns. Usually, we don't have much of a corneal burns because if you really don't focus properly, then you might come across with the corneal burns, or you may have a very shallow chambers. Those patients, you might have the corneal burns. So don't go too periphery. Once you go too periphery, then you might have this problem. Or if you don't magnify in your slit lamp, if you don't adjust your magnifications, you still may have the problems. So keep the magnification around the 25 so that you can really focus the laser beam on the iris and on the crypt. And always try to use the lens. The Abraham lens is always beneficial. If you don't use the lens and the patient moves, especially when the patient is going back, you might still hit on the cornea. So I would rather suggest to go for the Abraham lens. And if you have the band in the slit lamp, the headband, which you just tightly put it on the back of the head, so the patient doesn't move much. So this helps reducing the incidence of corneal burns.
So I think what he asked for is whether there is any kind of corneal decompensation post laser. That kind of issue, how frequently you are facing?
At least I haven't come across any patient coming back post laser with a corneal decompensation and causing multiple bullets. But nothing wrong in doing the specular microscopy. But if you don't know how to do the laser PI, if you can just follow the steps, probably you might be able to avoid all the problems. But it is not a very routine complication.
Dr. Harsh, any comments?
Yeah. 1% of patients may come across, but if you can just know how to do it, but even otherwise, some of the patients with the very, very shallow chambers, and if your focus magnification is not good enough, you still might hit on the cornea.
Yeah, I think
unmute, please, sir.
Unmute.
Yeah, okay. I think Satyan is absolutely right. There are a number of papers, especially from the Singapore people and others. But frankly speaking, I've been doing for 40 years and we have been following these patients for literally 10, 20 years. I have yet to see a patient who goes into corneal decompensation because of a peripheral iridotomy, even in the shallowest aphasia that we have. So I think it's a theoretical possibility. We have also reported, but it is very localized. And to add on the cost of the specular to that, I don't think is feasible.
Thank you, Dr. Satyan, and thank you, Harsh Kumar sir. We move on to Dr. Kirti for her talk. Please share your screen.
Is it visible?
Yes, clear.
Okay. So my topic is, are O kinase inhibitors here to stay? And as you can see, The punctuation makes a difference. Dr. Chandrama gave me a question, I'm giving an explanation. I have no financial interest to declare in this medication, and thank you very much, Dr. Chandrama and the Kolkata team, for having me here. So Dr. Pradeep, as usual, has made my talk much easier. So I'll just be covering on the language and the understanding part. So Rho is just a small G protein which is activated by various cytokines, and they have been found to regulate both cell adhesion, morphology, and above all motion, including smooth muscle contraction. As Dr. Das pointed out, trabecular meshwork and Schlemm canal both have been shown to have contractile properties, and that's what this drug is targeting. Rho kinase, on the other hand, are two isomers with the genes mapped on chromosomes. And these are the downstream effectors which are present at multiple sites in the eye, and that is why the versatility of this drug of Rho kinase inhibitors, because they are present in trabecular meshwork, in corneal endothelium, in retinal ganglion cells, as well as retinal blood vessels. The Rho kinase inhibitors disrupt the actin stress fibers and focal adhesions in the trabecular meshwork. In addition, they have a very interesting property of vascular smooth muscle relaxation, which causes vasodilatation. This aspect is both a boon and a bane. We'll come to that. So basically, Rho kinase inhibitors, or ROCKI, which I'm going to call it now for shortage of time, are pharmacological cytoskeletal manipulators. Born from the trabecular meshwork study group founded by Epstein in 1993 and preceded by their by their forefathers of cytokinesin and latrokilin, they decrease outflow resistance. So after pilocarpine, almost a century later, we have a drug which targets the outflow resistance. In addition to reducing stiffness in trabecular meshwork and increasing Schlemm canal pore size and surface area, it reverses the endothelium-induced vasoconstriction. Currently, 3 Rho kinase inhibitors are available in the market. In Japan, as Dr. Pradeep told you, it's been available. Fasudil has been available since 2011. It was for cerebral vasospasm. In 2014, Ripasudil came in, which is a fluorinated fasudil, and this was marketed for OAG and ocular hypertension in Japan. In 2016, Netarsudil came in, which is an amino isoquinoline amide, and this was marketed in OAG in USA. Now we come to the question, why do we need ROCKI? We have very effective AGM drugs, we have PG analogs, we have beta blockers, and we have a whole pharmacy there with us. But please remember, 50% of our patients of open angle glaucoma require polypharmacy to achieve target IOP. 30% of those on PG analogs require it, and 20% PGs are not effective. So add-on AGM very often required, and one of the mechanisms of AGM available is reduction of aqueous, and the fault doesn't lie at the ciliary body, which is being penalized. The fault lies at the trabecular meshwork, which is targeted by the ROCKI, and like pilocarpine, but without the side effects of pilocarpine. The first drug available was Ripasudil. I'm just going to skim over the drugs. Nocturnal effect is there. So as Ronnie pointed out very well, that nocturnal effect is very important for management of glaucoma, and this drug has it. And as I said, vasodilatation is a problem with this because it causes conjunctival hyperemia in the initial studies of more than 96% cases. However, it was transient. This nocturnal effect was very well demonstrated that this drug has a nocturnal effect, and that is why it has to be given twice a day. It has been used both as monotherapy, it has been used as additive therapy, and it is effective in multiple types of glaucoma, but in steroid-induced glaucoma, it has the maximal effect because it targeted the diseased meshwork by the steroids. It has adverse effects. As we said, vasodilatation is both a boon and a bane. Dilatation causes conjunctival hyperemia, which ranges from 76%, and mostly it is transient. This vasodilatation could have resulted in blood pressure dips, but it does not do that. The other problem is allergic conjunctivitis and blepharitis. The other drug is the Netarsudil or Ropressa. This has in addition the NETI inhibitor, and this NETI moiety, as Pradeep said, it reduces the epithelial venous pressure just like PG analogs and reduces the aqueous production. So since it has multiple effects, so obviously this drug is more potent than just the first ROCKI inhibitor. These trials, again, Rocket 1, Rocket 2, and Rocket 3 and Rocket 4 trials have been done already, multi-centric trials, and they have established the efficacy of this drug. And again, conjunctival hyperemia emerged as the most common side effect. One little scary side effect was corneal verticillata, which was there in these studies. This was tried to be used in BD dose, but BD dose, the effectivity was more, but adverse effects were much more. So nitarsodil now is given in a single dose form. The other drug which is available very recently is rocklatan, which is the combination of latanoprost and nitarsodil. And the Mercury 1 and 2 trials are the phase 3 double mask trials which have been completed. The adverse effects were pretty high, but only 7% patients actually discontinued therapy. And again, corneal verticillata came up as the effect, which was a little novel. However, the best part was that this verticillata were asymptomatic. So this rocklatan studies have shown that mean IOP of less than 18, which we all want, was achieved with that single therapy, which is a good option for glaucoma patients. So we have currently 3 types of ocular ROCI: ripasudil, nitarsodil, and rocklatan. IOP control is non-inferior to timolol. So let's read between the lines. That means it is not more effective than timolol. It is as effective as timolol. But the benefit over timolol is that it has a nocturnal effect. But the problem is it has conjunctival hyperemia. So as the status goes today, it's an adjunctive therapy, not first-line therapy. The best part about this drug is it has expanded role. It not only on the aqueous outflow, it has a neuroprotection role and a tenon fibroblast role. So let's come to that very briefly. The role of neuroprotection on retinal ganglion cells and improved blood flow is by the vasodilator effect, and that ROCK inhibition, ROCK expression is increased in glaucoma eyes. These have all been studies done over the last 1 decade, and this angiotensin effect is reduced by ROCK inhibitors. And that is why it causes vasodilatation at the optic nerve head arteries and increases blood flow there. In axon regeneration, it is useful because microglia signaling use Rho kinase, and ROCI inhibiting by glutamate induced excitocitosis increases the axonogenesis. However, these studies mostly have been experimental, and blood flow at optic nerve head also has been documented independent of IOP reduction. The most interesting part I find is when we have a failed bleb, the reduction of bleb scarring, because it acts on the TGF-induced smooth muscle actin expression, which is blocked by ROCI, and activated fibroblasts are reduced, which are critical in the myofibroblast transformation. Therefore, wound healing and scarring can be reduced. Therefore, it has a role in patients with operated TRABs in which you require a second AGM. There are in vitro studies both and experimental studies of cultured scleroblast. This is a very interesting study in which they induced glaucoma by anterior chamber bead injection, and they found that rabbit mice pre-treated with subconjugal ROCI, the response to scleral fibroblast proliferation was drastically reduced. So this has clinical implications. Only the secondary glaucoma I'm trying to highlight is steroid-induced glaucoma, because ripasudil has been shown to target the affected area, and this glaucoma is very rampant in India, so it can be used for these. We just talked about the ocular diseases, just 2 slides on that they have been shown to be effective in ocular corneal decompensation, and this study was there actually in the one which we were just talking about, post-PI and pre-PI. And this was a Fuchs corneal dystrophy. So these studies were in rabbits, but this study was actually in humans, in which they showed that ripasudil drops did result in a corneal haze recovery. And this is that PI corneal, that's very rare case, as Dr. Harsh and Dr. Satyan said. Even I haven't had any case, we only have corneal burns. But yes, as you can see, you can cause a corneal decompensation post-PI, and cultured endothelial cells, including ROCK inhibitor injected, did result in this patient not requiring a graft. One role of diabetic macular edema also is there, but this is beyond the purview of this lecture. So multi-pronged, in conclusion, that's a multi-pronged therapy for glaucoma. It has beneficial effect at optic nerve head by improving blood flow. It improves retinal ganglion cell survival. It can reduce definitely bleb failure. It can be the first line drugs in GFS, glaucoma filtering surgery failing. In secondary glaucoma, especially steroid-induced and uveitic, it may become first line. In primary glaucoma, it's an adjunctive, not the first line therapy, and only for open angle glaucoma variants. And it has other features, other aspects of ocular disease and corneal decompensation and diabetic macular edema. So definitely rho kinase inhibitor, the new drop on the horizon, is here to stay. Thank you.
Thank you very much, Dr. Kirti. That was indeed a very informative talk, and what I understand from it is ROCK inhibitors are here to stay in a more modified and better form. With that, we move on to Dr. Jyoti. Dr. Jyoti can share the screen and start. So good evening, everyone, and I thank Dr. Chandrima and Kolkata Ophthalmic Society for giving me this opportunity. And I'll be talking about the equation of systemic medications and glaucoma. So when we are treating glaucoma of our patients, their physicians are treating their systemic comorbidities. And there's a huge list of systemic medications which can actually be detrimental to the glaucoma status of the patient by increasing the intraocular pressure, either through the open angle mechanism, where the steroids are the culprit, or through various angle closure mechanisms where drugs acting on the autonomic nervous system or those causing idiosyncratic reaction, or sometimes the anticoagulants are the culprits. So as far as the steroids are concerned, they can increase the intraocular pressure in susceptible individuals called the steroid responders, which form around 5 to 6% of the general population. It can increase the intraocular pressure within days to weeks when used on a topical basis, and may take a little longer when used on a long-term systemic use for conditions like rheumatoid arthritis, SLE, etc. So in a dilating pupil, there are tissue stretch factors which actually create vector forces which press the pupil against the anterior lens surface in the mid-dilated position, which is known as dynamic pupillary block, which happens to be the major contributing mechanism in the drugs of the autonomic nervous system group, which causes trapping of the aqueous humor in the posterior chamber, pushing the peripheral iris against the trabecular meshwork. The other thing is that the dilator pupillae muscle is located along the posterior surface of the iris near the periphery, and its contraction causes buckling up and anterior bowing of the peripheral iris, with a tendency to increase the iridotrabecular meshwork contact. And the studies have shown that the eyes with angle closure glaucoma are relatively incompressible during dilatation, in the sense that they tend to retain their bulk and volume. And this in the peripheral part can again lead to increased iridotrabecular meshwork contact, leading to angle closure. So anticholinergic drugs with their acting on the sphincter pupillae and the sympathomimetic drugs acting on the dilator pupillae can bring about increase in the intraocular pressure. At risk in the at-risk population, which are the older female or those who already have the compromised biometric parameters like shallow AC, hyperopic lenses, bulky crystalline lenses. In young, it could be the plateau iris as well. So as far as the respiratory system is concerned, majority of the drugs have the sympathomimetic activity, where the epinephrine we know is used as for the management of allergic reaction, anaphylactic shock, and OTC drugs, nasal decongestants, antitussive, everything has nefazoline, ephedrine, and other drugs which have sympathomimetic activity. Drug used for asthma management, salbutamol, also has this activity, but especially when it is used with ipratropium bromide, which has a strong anticholinergic component, and the combinations are very commonly used, especially when used in a nebulized form, can be really detrimental. In the cardiac group of drugs, diisopyramide is used as a management for cardiac arrhythmia, has an anticholinergic effect, and epinephrine, when used for the ventricular fibrillation, has a sympathomimetic activity. Certain anticoagulants very rarely have shown a sudden spontaneous choroidal hemorrhage, especially in conditions like wet ARMD, etc., when neovascularization is already present, and they can push the lens iris diaphragm anteriorly, suddenly increasing the intraocular pressure. So as far as the central nervous system is concerned, almost all the medications that are used have good anticholinergic activity. Antipsychotics like perfenazine, trifluconazine, which are used in the management of schizophrenia, bipolar disorders. And then there are antidepressants, the selective serotonin reuptake inhibitors, of which the paroxetine causes the most, and then the other medications. They all have anticholinergics and serotonergic activity. Now, serotonin can cause partial pupil dilatation and also can increase the aqueous humor production by increasing the ciliary body blood flow. Citalopram with regular dosage has been shown to produce acute angle closure attack. Tricyclic antidepressants, amitriptyline, imipramine, very strong anticholinergic drugs, and then tetracyclic antidepressants and MAO inhibitors all have anticholinergic activity as well.
On the other hand, other antidepressants have sympathomimetic activity like norepinephrine reuptake inhibitor, reboxetine being the prototype, and then venla and desvenlafaxine are the serotonin and norepinephrine reuptake inhibitors, both properties. Mirtazapine is an atypical antidepressant, has been shown to induce acute attack. All anxiolytics, benzodiazepine group of drugs, anti-Parkinsonism drugs, spasmolytics, H1, H2 receptor antagonists all have anticholinergic property and have the propensity of causing this type of dilatation. Ecstasy, used as a recreational drug, has a sympathomimetic as well as serotonergic activity. On the other hand, it has sometimes been shown to have a uveal effusion type of an idiosyncratic reaction as well. Cocaine, again, is known to produce acute angle closure glaucoma with sympathomimetic activity. Other drugs of the similar group could be anti-hemorrhoidal suppositories with epinephrine, and then amphetamine, still used as anorexians, etc., can produce this type of effect. Botulinum toxin, on the other hand, is used to for management of blepharospasm and for cosmetic purpose, is an anticholinergic. Now, the issue is that it can diffuse into the ciliary ganglion, and the mydriasis can last for a little longer period of time. Anesthetic agents have been known to produce acute angle closure glaucoma attack, especially in long-standing surgeries on prone patients like spinal surgeries, and on top of that, psychological stress is producing endogenous catecholamines, and dark-induced mydriasis is there. And then almost all the drugs that are used either in the to give the anesthesia, to maintain, or to bring the patient out of it are all the autonomic nervous system acting drugs like atropine, scopolamine, ephedrine, and epinephrine. Certain anti-cancer agents have also been known to produce and increase in the intraocular pressure. Now, coming to drugs which have been known to produce a typical type B reaction, which happens in one patient and not in others. So we do not know the exact mechanism. The possibility of it being an idiosyncratic reaction is definitely there. And these are the sulfa-containing group drugs like antibiotics, cotrimoxazole, diuretics like acetazolamide, and then sulfonylureas, rheumatology drugs, and drugs like topiramate is a villain here because many cases have been reported. And the issue here is that supraciliary fluid accumulation occurs because of the ciliary body and choroidal effusion, which pushes the lens iris diaphragm anteriorly, and bilateral shallowing of anterior chamber, myopia, and raised IOP is seen in these patients. Certain drugs which were known to act only on the autonomic nervous system like escitalopram, venlafaxine have also been reported to have a uveal effusion type of idiosyncratic reaction. Now, when idiosyncratic reaction occurs to a particular group, particular drug, the only thing to be done is to take care of the patient symptomatically, reduce the pressure, but then we need to document it so that it is never used by anyone in future. And the other issue is that probably there is a cross hypersensitivity with other sulfonamides, so it would be prudent to not to use carbonic anhydrase inhibitors and acetazolamide in managing such patients. And then we need to coordinate with the treating physician to shift to non-steroidal alternatives when possible, if the steroids are the culprit, or to shift the nighttime dosage, as Dr. Ronnie has already said, to the daytime dosage, because it could be because of the nocturnal dip in the blood pressure, which is worsening the glaucoma. And we need to request them to refer these patients to us when they are starting on the drugs that we have already talked about, so that we can assess whether a prophylactic iridotomy is required or not, or we can follow up the patients on a regular basis, because this can happen not just an acute attack but intermittent attacks leading to chronic angle closure glaucoma as well. We also understand that it's not possible to refer all the patients, but at least a physician should be able to assess whether the patient is hyperopic or has a family history of glaucoma, and especially when he's using a combination drug like a salbutamol with an ipratropium bromide, he can at least do a pentorch examination and assess the anterior chamber depth, and of course he has to refer when the patient is complaining of an ocular problem. And we should, it's very mandatory, we should keep it as a protocol to keep a list of the systemic medications that the patient is on, and we need to update it on a regular basis because the drugs can keep on changing. There is another angle to this equation between the systemic drugs and the glaucoma, because certain drugs have shown a strong protective association, like for the selective serotonin reuptake inhibitors for POAG, and certain other drugs like metformin has also shown that effect. We also need to keep in mind that beta blockers, when given by the physicians on a systemic basis as antihypertensive, has a propensity to decrease the intraocular pressure as well, which if the physician chooses for whatever reason to shift the antihypertensive to another group of drug which does not decrease the intraocular pressure, the pressures would increase, and then it would destabilize the glaucoma status. So thank you so much.
Thank you very much, Dr. Jyoti. That was indeed a very informative talk. We move on to Dr. Shainur. Dr. Shainur, please share your screen and go ahead. Dr. Jyoti, you need to stop sharing your screen. Yeah.
Is my screen visible?
Yes, yes, Shainur. You can go to the slideshow mode.
Good evening. Yeah, good evening. I thank Kolkata Academy of Ophthalmology for giving me this opportunity. I'll be talking about laser trabeculoplasty. It was first described in 1973 by Worthen and Wickham. Argon laser was used for the purpose. Then in 1979, Weiss and Witter used it to treat medically uncontrolled glaucoma. Then there was a multi-center randomized clinical trial, that is the glaucoma laser trial, which was undertaken to study the efficacy and safety of argon laser trabeculoplasty versus standard medical therapy in primary open-angle glaucoma. Without going into the details of glaucoma laser trial, I'd just like to highlight the conclusions made by this study. It said that laser trabeculoplasty as initial therapy was at least as efficacious as topical medication. So in this study, 11% of the ALT treated eyes required a repeat ALT or filtering surgery, and 34% of the medically managed eyes required an ALT or filtration surgery. So despite favorable results, this trial had very minimal impact on the practice patterns of glaucoma specialists. It was probably due to the attrition of efficacy over time and also the introduction of more effective anti-glaucoma medications, that is the prostaglandin analogs. So the role of laser trabeculoplasty was limited to adjunctive therapy or an intermediate step between failed or insufficient medical therapy and filtration surgery. Now, what is the role of laser trabeculoplasty in the treatment of glaucoma? So in this procedure, tiny laser shots are applied to the trabecular meshwork, and tiny laser trabeculoplasty, just excuse me. In this procedure, tiny laser shots are directed to the trabecular meshwork, which causes opening up of the Schlemm's canal and facilitates lowering of intraocular pressure. Two commonly types of laser trabeculoplasty used are the argon laser trabeculoplasty and the selective laser trabeculoplasty. In 1998, Latina introduced the SLT or selective laser trabeculoplasty. It is a Q-switched 532 nm ND YAG laser, a non-thermal laser. There are two theories which explain the mechanism of action of ALT. One is the mechanical theory, which states that when thermal energy is directed to the trabecular meshwork, it leads to focal scarring, which causes mechanical stretching of the untreated areas, and there is an increased flow of aqueous into the Schlemm's canal, thus lowering the intraocular pressure. The biological theory states that following laser, there is inflammatory cytokine release, which causes stimulation and increased cell division in the untreated areas, which lead to repopulation in the treated area, and these are effective in phagocytosis and produce extracellular matrix of a different composition with improved outflow facility properties. Now, the exact mechanism of SLT is not known. There is selective absorption of energy by the pigmented trabecular meshwork cells and sparing of the adjacent cells and tissues from thermal damage. Histology shows that there is less coagulative damage and there is less structural damage of the trabecular meshwork as compared to ALT, in which it has been shown that there is fusion of the outer and the inner wall of the Schlemm's canal. Now this is an electron microscopy image. In the first one, we see crater-like damage to the trabecular meshwork following ALT, with no notable change seen following SLT. Now there are a number of reasonings why laser trabeculoplasty can be used as primary therapy. There are issues with medical management. Patient participation is required, and with multiple medications, the individual's quality of life is affected. Also, there are side effects of the anti-glaucoma medications which can be minimal or quite significant, and also the cost of lifelong treatment has to be considered. There is one publication which states that chronic use of prostaglandin analogs cause change in the corneal biomechanical properties like the corneal hysteresis, which affect IOP estimation. However, this is a reversible change. In another study by Nagar et al., 180-degree SLT versus 360-degree SLT was compared, and they found that 360-degree treatment was as successful as latanoprost eye drop. Also, IOP reduction was found to be similar in both medication and the SLT group as initial therapy. Now, this is a rich gonio lens which is used for argon laser trabeculoplasty, and the second one is the Latina 5-bar indexing SLT lens. It has the advantage of this is that it has a rotating ring which the user can use while doing the laser for rotating the lens without using both the hands. Also, there are 5 high contrast reference bars which are spaced 500 microns apart for better positioning of the laser spots. Now, comparing the SLT and the ALT parameters, the pulse duration for SLT is very less compared to ALT, only 3 nanoseconds. Also, the spot size for SLT is much larger, 400 microns. Since the laser is absorbed by the pigment cells, precise focusing is not required. Also, the energy used for SLT is in millijoules and much less as compared to that used in ALT. The advantage of SLT again is its repeatability, whereas ALT cannot be repeated, particularly in already treated areas. Some of the pearls for ALT are the inferior 180 degrees treated first. Since the response is delayed by 6 weeks, the interim period has to be managed with medication. Pearls for SLT is that for best results, 360 degrees have to be treated. Watch out for increased trabecular meshwork pigmentation because these are the cases where post-laser IOP spike may occur. So low energy settings are required in these eyes. Topical anesthetic.
Sorry
Yes?
to interfere. Sorry to interfere. Can you sum up quickly? We are running late actually. Yeah.
Okay. So the topical NSAIDs can be used for 2 days. That is usually sufficient, but sometimes steroids are required. And one of the strongest predictor for success is the baseline IOP. Now, complications mainly for ALT are if the laser is not applied properly can lead to PAS and endothelial cell disruption, and also the AG's study has reported increased bleb encapsulation in ALT treated eyes. And the complications with SLT are lesser. One unexplained and rare complication is a corneal edema. So to conclude, if the proposal to consider laser trabeculoplasty as initial therapy for newly diagnosed glaucoma treatment causes a lot of it poses a lot of question to our knowledge or our practice of glaucoma till now. But the proponents of SLT have very compelling arguments to make this major change. In India, however, we have to consider the ground realities. One is the availability of SLT, how many centers have SLT actually, and the applicability of the studies which were conducted in wide population. There are very few studies done in India, and that too they have noted modest results. And lastly, the treatment with laser does not eliminate the need for medication. So considering these ground realities in India, it still remains an adjunctive treatment as far as the treatment of glaucoma is concerned. Thank you.
Thank you, Shahinur. That was a wonderful presentation. May I call Dr. Manavdeep Singh, sir, to share his presentation?
Thank you.
Dr. Singh, please.
Thank you so much, Calcutta Academy of Ophthalmology and Dr. Chandrima. And is my screen visible?
Yes, sir, it is visible.
It is visible. But it's not moving. Moving. No. Okay.
Yes.
So what is this? Again, not moving.
Can you use the arrows?
Which arrows? Yes.
Yeah, we can see.
Now it's moving again. Thank you.
Yes.
So I'll share with you in next few minutes about the problems that we face in the patients of glaucoma with corneal disease. The first and foremost problem is the intraocular pressure measurement. And as you all know, GAT is not very accurate, and tonopen-like instruments are better for this. And in cases that cornea is partially affected by opacity or something like that, and then we can use a smaller area of contact like instruments. And of course, in any infected or injured eye, no touch technique should be used. The problems which we face in the patients with corneal disease include the pre-existing corneal disease, so they may be intolerant to certain drugs. Drug toxicity. I want to remind you all that we only discuss about the under treatment, but we should know that 50% of the patients are actually being over-treated, thereby causing drug toxicity, adding to the drug toxicity. The preservative toxicity is no less. There are allergic reaction, and there can be reactivation of corneal disease by the use of these drugs. All these groups of drugs are well known to all of you, and but one should remember that there are different drugs from the same group may have different effect on the cornea. So we should begin the therapy with a single drug so that we use minimum number of drugs. The drug should have maximum efficacy, high compliance, and reasonable cost. Unilateral trial should not only be used to assess the efficacy, but also to see if any side effects in a bilateral corneal disease. The first choice is generally the PG analogs everywhere, because they are most effective, and the side effects include the inflammation, which can cause reactivation of the anterior uveitis as well as herpes simplex keratitis, although it is equivocal in certain studies. Rarely it can cause dendritic form epitheliopathy, and mild punctate epicorneal erosions have also been reported. Therefore, the contraindications include the patients with risk factors for CME, iritis, HSV keratitis, or immediate post-operative surgery. One should remember that bimatoprost has got maximum side effects, and the trifluprost is the most innocuous of these drugs. The beta blockers have very little topical side effects, and however, they may exacerbate the existing dry eye, and with a chronic use, they cause decreased tear production and goblet cell density, thereby causing stinging sensation, and all this increases with the use of benzalkonium chloride. The alpha agonists are the biggest problem for us, causing corneal problems. They have side effect of hyperemia is almost seen in 30%, and periocular allergy has been reported to be in 9 to 16% cases within 1 year. However, I'm sure that this increases over a longer period of time. If the treatment is continued, it can cause severe ocular surface disease, and at the end, it can cause even granulomatous uveitis. This is one of our cases who had brimonidine-induced severe ocular damage, resulting in the vision of 660 from 6.9. The same patient had granulomatous uveitis as well. As far as carbonic anhydrase inhibitors are concerned, dorzolamide is far more causes corneal problems compared to brinzolamide, which has got a pH which is close to normal, whereas dorzolamide is much less. It causes stinging, burning, allergic conjunctivitis, SPK, blurred vision, discharge, watering, foreign body sensation, and even corneal erosions. The most important thing is about the endothelial cell damage. It does not happen in a normal eyes. However, in the eyes with pre-existing endothelial problems, this can be a problem. And the systemic carbonic anhydrase inhibitors, they are sulfa, and so they can cause all sulfa-like problems to the cornea. Pilocarpine is a wonder drug, I feel, and causes little ocular surface related side effects. However, it is contraindicated when there is already an existing active conjunctivitis, keratitis, and in the immediate post-operative period. The Rho kinase inhibitors have been discussed by Pradeep and Kirti, but at the moment it is too early to really comment about their long-term problems. The role of preservatives, as I said, these are the commonly used preservatives. This was thiomersol, which is no more used now, which could cause this kind of a problem. And you can see here that the drops with preservative, they can cause far more symptoms than without preservatives. So it's not only the drug, but also the preservatives which can be the cause of corneal problems. And this is this bar chart shows a decrease in the clinical signs on switching from preservative to preservative-free drugs in case of dry eyes. And compliance in these cases is extremely important, much more important than a usual case, because the treatment of each patient should be individualized with minimum drugs. The adherence and compliance are major issues. They are in symptomatic corneal disease. The increased number of drugs due to those added for corneal disease reduce compliance. And there is always a tendency for selectively avoid anti-glaucoma drugs as they increase the symptoms, whereas the artificial tears, they give relief. Thus, to summarize the treatment principles of glaucoma patients with corneal disease, we prefer the preservative-free drugs, supplement the treatment with artificial tears, start with PG analog, and the most innocuous being trifluprost. Beta blockers are less effective than PG analogs, but they can worsen dry eye. However, they don't have many other side effects. Alpha agonists can cause severe ocular surface disease. Carbonic anhydrase inhibitors should be avoided in pre-existing corneal endothelial problems. And when we require multiple drugs, fixed dose combinations are always better for better compliance and lesser side effects related to the preservatives. And the threshold for surgery should be lower in these cases, and when filtration surgery is undertaken, preoperative steroids should also be used to increase the success of the surgery. Thank you very much.
Thank you, Dr. Manavdeep. That was indeed a very well-tailored talk. Thank you very much. We move on to Dr. Barun Nayak, sir. Dr. Nayak, sir, you can share your screen and start talking.
Yeah, I'll just share. Yeah, can you?
Yes, sir.
Power, it is not coming, power.
Perfect.
Yes, now it has come, yes. Okay,
yes.
So I'm just going to point out certain care that we have to take while prescribing, while writing prescription. And now this is the ethical as well as professional responsibility as a doctor. And this we must have read during pharmacology days, that these are the various parts of a prescription that we should try to include in that. And when Mrs. Patil was the President of India, that time she had said more than 50% of prescriptions drugs are wrongly used, which is worldwide. And one of the reason that means because doctor's handwriting, it's very famous that if anyone, a good doctor means its handwriting should be bad. Because it's written here in this, that the report says medical errors such as indecipherable prescriptions cause the deaths. So those things means, it means that basically it just highlights the point that it has to be very legibly written. These days, fortunately, we are writing all giving type prescription. But what the other part is that the one is that it has to be legible and clearly written. The second thing we should take care that at least the right patient, right drug, right route, right dose, and right time. These 5 elements must be included in the prescription. So apart from being making it very clear, it has to be very, means those 5 things must be included. So no sloppy handwriting. Order should be simple and clear in plain English, and abbreviations and other that should be avoided, because no Latin abbreviations. I'll show you some of the abbreviations which really patient cannot understand. And the third part of prescription writing is that mistakes which are being done. So those 2 already I pointed out. The third one, that the philosophy of medication, because thinking that what medicine should we give, because that is also part of we write prescription whatever our mind thinks. So the treatment, that already the discussion which has been going on and some medical treatment and what medicine to be given. So that also we have to think properly, that in which disease what medicine to be written. So in glaucoma, just 2-3 points I'll highlight. So I follow this dictum. Always I show LP Agrawal's dictum: no medication is best medication, and least medication is best alternative, and above all, do no harm. So basically, if you write more, there will be more damage to the patient. Now, this is example of one. It's just see, can anyone read anything what is written on top? But then this one, just see this. The name which is written here, that the patient got, the doctor wanted to write Prozac, but the pharmacist read it Buspar. And Prozac and Buspar, because the patient was of depression, and patient was given the Buspar which was anti-anxiety means the anxiolytic agent. So it's basically the reverse treatment the patient got. Similarly, here also, just if you see the whatever is written, I am sure, unless I show you, means now you will see that yes, both can be written Vantine as well as Vasotec. Patient was hypertensive, so the doctor wanted to write Vasotec, but the pharmacist read it Vantine, which is antibiotic. It's a form of antibiotic. Now in glaucoma, to be particular, like the dose, what time it should be given. If it is single dose beta blocker, it has to be morning, not at the night. Then similarly, there were some abbreviations. ED means how the patient will know what does the ED mean. Now here means just the same prescription, iotine 0.5% eye drops, 1 drop in each eye in the morning, follow up after 4 weeks. So at least something written, full eye drops is written full, no abbreviation, also given some instructions. So like this, it has to be complete. Xalatan, these are all real prescription I have typed in. Xalatan eye drops, 1 drop in each eye twice daily, which is not the right dose. Now Ganfort and Dorjox T, both given, also written here, those abbreviations, plus Ganfort and Dorjox T, both contains one of the element is the same, which is beta blocker. Same here, that giving systemic beta carbonic anhydrase inhibitors as well as local, which is for a short period, for a day or two, it's okay because you have to overload it, but not for long term. Now Glaucomol, Bitoptic, in the same prescription, both writing is both from the same class of drug. Only thing one is the selective, other is non-selective. Timolol, in this prescription also, if you see Dorjox T and Iopar, both elements are same, Timolol and Dorjox T. So it is the same. Now these are some of the, just like you see how careless we are in writing prescriptions, that here it's written ED. What the patient will understand, ED means what? The Enforcement Directorate, these are a lot of talk going about Enforcement Directorate. Then what is no other detail, means whether it has to be used in the eye or what is to be done, nothing is given in detail. Similarly, and plus the combination also was wrong. The Combigan as well as Travacon, both has got one element same. Same thing here, but here again, it's something not written in full detail. Locally BE means patient, because we think that we always talk about BE means both eye, doesn't mean that patient also understands the same thing. Now here, now it is see this irony. Now whatever is written ED, eye drop, patient, I don't know will understand or not, BE. Now here it is written OD. Now OD, here it is written BE, both eye. Here it is written OD, means for right eye. So whether it's once daily or right eye or whatever, so plus follow up with fields. Now follow up like this abbreviation, how do you expect that patient will decipher this? So please take care of these problems. It should not happen. Again, the similar kind of thing. Now TRAP under GP explained. Now patient, what does patient, suppose patient goes with this, shows to anyone else, who will miss anyone who is not ophthalmologist, probably the ophthalmologist also will thinks over some time that what he has written, that trabeculectomy under guarded prognosis and all those things. So that those things we have to take care. So combine different, and also in writing glaucoma medication, combine different drugs with different mode of action, and do not combine drugs from the same class of drugs. And this is from the EGC, European Glaucoma Society guidelines. We must adhere to this, means we cannot over-prescribe. And so always remember, always write with which is legible, always space out words and numbers to avoid confusion, always complete medication orders, avoid abbreviation, and when in doubt, definitely verify, ask to verify, not like this where the pharmacist read, that's what it says, 1 tablespoonful 300 times a day. This is what the prescription says. So is it possible? Pharmacist will think that 300 times a day, but then he is giving it 300 times a day. So it's better at this kind of thing. If suppose someone comes across, then they should verify. Thank you very much. I am sure with this, at least we will definitely take care and will be little more careful and cautious in prescribing medicine and writing prescriptions. So it should be clear, it should be complete instructions, and it should be medication that we are giving after a proper thought process we should prescribe. Thank you very much, and thank you Dr. Chandrima, and thank you KAO for giving me this opportunity. Wonderful opportunity. Thank you.
Thank you, Dr. Nayak. Those were indeed very useful guidelines for all of us to be careful when we're writing our prescriptions in our busy clinics. Thank you very much. With that, we move on to the last speaker of this session, but she's in no way the least, because she's one of the brightest glaucomatologists that we have around in the GSI, Dr. Shweta Tripathi. You can share your screen and go ahead.
Thank you, ma'am, for the kind words. So a very good evening to all, and I would like to thank the entire organizing team of this KAO for giving me this opportunity, and straight away coming to my topic of glaucoma compliance, and it's all about facing the challenge. Let's see how. So when we talk about the grave situation and the grave situation caused by the glaucoma-induced blindness, my slides are not changing. Yes. Just a second. Yes.
Yep.
Yeah, thank you so much. So when we look at the glaucoma-induced blindness, we see that it's a major problem, and there are some major challenges which comes across when we talk about treating a glaucoma, diagnosing a glaucoma, say starting from the underdiagnosis to the overtreatment. But what say, suppose if the diagnosis is made correctly and the patient is put on the anti-glaucoma medications. So the next challenge comes to us in the major form is the compliance, because we know that compliance comes only when the patient is aware of the symptomatic or the asymptomatic nature of the disease or the benefits of the anti-glaucoma medications, which are not very much obvious to the patients. Because by the different studies, as stated, they said that the ignorance was a major cause of the poor health-seeking behavior, to such an extent that in a study it was stated that 39% of the patients were diagnosed to an advanced stage. So now let's address that what is the distribution of this non-compliance. That is from 20% to 60%. That's a huge amount. And now we need to address a very important question here, that does the compliance really affects the treatment protocol? And the answer to this is going to be definitely a big yes. Let's see how. That's because if say suppose we have put the patient on a anti-glaucoma medications and still the target IOP is not getting achieved. So it is very much possible that there is a tendency to change the medications or switch on to a additional alternative therapy. That itself is going to cause the burden on the pocket of the patient. That is, we know that glaucoma treatment is a lifelong treatment, and the patient has to be a pocket friendly this thing for the treatment to be continued. Also, the keep on addition of the eye drops leads to the compromised quality of life. Sometimes we just pose the patient for unnecessary investigations, and the wrong surgical decision is made due to the thinking of that the disease is progressing. Actually, it is the non-compliance or adherent nature of the patient, because we all know that the goal of the glaucoma treatment is not only about lowering of the IOP. It is something much more to that is, along with the IOP lowering, the adherence has to be there, causing and giving the patient a good quality of life with the preservation of the vision loss. So we as a treating glaucoma people, we do have an additional responsibility of making our patients more compliant, more adherent, and more persistent. And just simplifying these terminologies, we are going to just simply talk about the most relevant terminology here, that is adherence. Adherence is something, a mutual understanding kind of thing between a healthcare provider and the patient itself. It is not simply recommending the treatment. It is that we explain it to the patient, and patient is taking participation in the decision making, and that's how he is going to be more compliant or adherent towards the treatment. So from henceforth, now in the subsequent slides, we are going to use the correct term, that is adherence. So when we talk about the different dimensions of adherence, it is the health factors and the therapy related factors, as quoted by Roderick and et al., being the most common, being the side effect was the most important for the patient, making more non-adherent towards the treatment. And the second was the lack of awareness, that is the knowledge about the disease. So if we want to categorize the non-adherence, it can be subdivided into two subheadings: the unintentional, that is the practical barrier, and the intentional one. The practical barriers enumerating, though we all know that, just going briefly through that, that is talking about the, say, about the lifestyle. There are two extremes of the lifestyle. Either the patient is living all alone, or the patient is having a busy lifestyle. And in both the scenarios, the complexity of the regime, the frequency of the eye drops, or the complex instructions are definitely going to hamper in his daily day-to-day activities, and he's going to shy off from the use of the AGMs. Similarly, when we talk about the elderly individuals, the cognitive barriers may be in the form of poor memory or something like a poor dexterity problem. That is, it might seem to us very simple, that squeezing an eye drop bottle, but for a patient who is having arthritis, for him it is a major task of the day that he has to squeeze the eye drop twice in a day to put the eye drop in his eyes. And the last but not the least would be the education, that is the lack of knowledge. Definitely, if the patient is, we say in a common language that ignorance is bliss. So if the patient is not knowing of the disease, definitely he might shy of the drugs. So to overcome these practical barriers, we do have the communication. So if we overcome the communication difficulties between the patient and the physician, definitely the practical barriers are going to be taken very well care of by the treating physician. Now, there are certain strategies to improvise these practical barriers or the non-adherence things. So for that, the education about the knowledge, definitely we should keep some pamphlets or the written or the verbal communication and the training sessions to the patients when they are sitting and waiting in the waiting area. Some written matter can be given to them in the form of pamphlets so that they can read about the disease. Not talking about simplifying the regime, the fixed dose combinations can be given instead of using multiple bottles. Reminders and alarms can be set, or the drops can be linked to daily activities for the elderly individuals who do have cognitive barriers, or the person who is having a busy lifestyle. Now the patient who is having some problem like dexterity problem, which we are talking about, for them the rescue has come as the dose administration aids. And last but not the least, and the most important part, we sitting in a clinic can take care there itself would be the proper installation technique to the patient, the demonstration of this technique with a punctal occlusion. And we all know that it improves the absorption of the drug. Then there are certain strategies to improve the intentional non-adherence. And in all, we can say that it is only education, because the intentional barrier is simply a patient's myth or belief that this is not going to get cured, or there is no immediate gain in the vision, or nothing is happening to him in the early glaucoma stages. So it is our double responsibility through a proper counseling that definitely we have to explain the patient about the nature of the disease, and we have to explain him that his expectation that immediate gain in the vision is not going to happen. So as a treating ophthalmologist, our target is going to be the primary concern for the glaucoma patients. And that is what it should, like, the primary concern is side effects, because I'm sure that none of us wants the patient's eye to be like that, and none of the patients want their eyes to be like that. Probably drug induced or a preservative induced. Disruption in the daily activities, or any kind of belief. Again, I should say that it can be taken care by the counseling. The alternatives drugs can be used, or preservative-free drugs are there. So at the end, what do we do actually? There are certain points which we should keep in mind, that when we are writing a prescription or we are treating the patient, that the patient is not a first timer for the glaucoma treatment, because definitely he is going to be apprehensive and he might shy off from the treatment. Also, a combination therapy can be given. A systemic medication theory is definitely going to be kept in mind. Also, we have to take a history of contact lens usage, the time of administration, and ask for the female patients, we have to ask about their pregnancy and breastfeeding histories. So there are certain golden rules which we need to keep in mind while writing the glaucoma prescription. That is, keeping in mind about the combination therapy, cost, and the comorbidities. And in the last, I would like to summarize saying that a regular follow-up with a reassurance is definitely going to convert a non-adherent patient to an adherent patient and will help us to achieve the goal of preserving the patient's vision. Thank you.
Thank you, Dr. Shweta. Indeed, you dealt very effectively with a very important part of the treatment that we all actually go through. Compliance is one of the things which we find very difficult in our day-to-day practice. Thank you very much. With that, we'll move on to Dr. Arijit to share to present his first case.
Yes, ma'am. Is my screen visible?
Yes, yes.
Okay. Thank you, Chandrima ma'am, and thank you, Kolkata Academy, for giving me this opportunity. My presentation is titled Post-PI Debacle. So obviously it has something to do with a PI. So I would first like to just go back in time. So this was a case which I dealt with in 2014, where a patient presented with an acute attack of angle closure in her right eye. So I did a PI in both eyes, and post-PI, after 5 days, this is what the patient landed up with. So this was the right eye, which already had some amount of glaucomatous damage. And there was an exudative retinal detachment along with a choroidal detachment in both eyes. So this was a CD plus ERD in both eyes post-PI in a case where the axial length was a little bit on the smaller side. The right eye was 21.2 and the left eye was 21.1. I tried to publish this particular case. However, the peer reviewers came back to me saying that this is common in nanophthalmic eyes, and now the definition of nanophthalmos is changing. So this can be considered to be a nanophthalmic eye. So this was in 2014. Now I jump to my case. This was a 46-year-old female who came with the complaints of sudden onset of pain, redness, and dimness of vision in her right eye for the past 1 week. These images have been taken later because we usually don't photograph acute attack patients at the first go. So she gave an interesting history that she had a similar complaint in the left eye 3 months ago. And she was treated for the symptoms in the left eye with topical drops and oral tabs, and the vision subsided, but some sort of a discomfort has persisted since then. So when we looked for the records for the left eye, they were not there, but for the right eye, we saw that the ophthalmologist who had treated her had noted an IOP of 54 in the right eye and 14 in the left eye at presentation. She was already on brimonidine, pilocarpine, and oral acetazolamide tabs. There was no history of trauma, no history of any ocular surgeries. Both mother and maternal grandmother had glaucoma, but she couldn't specify whether they had undergone any laser treatment. Her vision uncorrected was 618, improving to 612 in the right eye, and 612 improving to 69 in the left eye. When we looked at the anterior segment, there was ciliary congestion in the right eye. There were few KPs and pigments at the back of the cornea in both eyes. Both eyes had some degree of flare, and right eye had 1+ cells. In the right eye, the pupil was mid-dilated, not reacting to light, with posterior synechia, and she had an incidental finding of developmental cataract in both eyes. The IOP was 42, even though there was not much corneal edema at the moment. Gonioscopy showed there was PAS in the superior nasal and temporal quadrants in the right eye, and intermittent PAS in the superior and the temporal quadrants in the left eye. When we looked at the posterior segment, what we found was that both the discs were small with a 0.2 CDR. There was mild disc hyperemia in the right eye, and the periphery, immediately the fundus struck us because there was depigmentation. There was an orange-red sunset glow fundus with patchy RP clumping in both eyes. The axial length I've mentioned are normal in this particular case. I've just mentioned it because of the previous case that I'd encountered. So this was what the fundus picture looked like. This was not taken on that particular day. This was taken later on. So you can see this patchy RP clumping and the orange-red glow of the fundus. So the diagnosis was an acute attack of angle closure in the right eye with a probable history of acute attack in the left eye in a case of probable or ocular VKHD or Vogt-Koyanagi-Harada disease. Now, there are 3 criteria to diagnose it. Number 1, no history of previous penetrating ocular trauma or surgery. Number 2, no clinical or lab evidence, and bilateral ocular involvement, all 3 of which were there in this particular case. So I went ahead and I did a PI, because that's what the literature says, that if you have a case of VKHD with an acute attack, you do a PI. So I did a PI, and the energy wasn't too much. There were 3 shots of 5.2 and 4 shots of 5.2 again in the right eye. So there were 2 PIs which I did in the right eye, and the left eye there was a single PI of 4 shots of 5 millijoule. I kept the patient on a combination brimonidine timolol fixed dose combination, oral prednisolone acetate, oral tablet prednisolone because I was expecting some sort of inflammation, topical prednisolone, and oral acetazolamide. So these are the 2 PIs. Again, these photographs were taken later, and there was the single PI in the left eye. Now, what happened was, after 5 days, the patient presented back to me, and the visual acuity had dropped drastically. 660 uncorrected in the right eye, 636 in the left eye, which wasn't improving too much. The IOPs, however, were normal. So this is what I found when I looked at the posterior segment, that there was serous effusion of the macula with choroidal detachment and non-ray Gardi in both eyes. So this is the Opto's wide field fundus photography in straight gaze. This is in up gaze in the right eye. This is straight gaze, and this is up gaze in the left eye. This is the OCT macula of the right eye. You can see a huge amount of serous fluid with a central foveal thickness of 852 micron. In the left eye, there was a small amount of serous fluid with a CFT of 438 microns. So the treatment, which I referred to the retina colleague, he asked me to continue my own treatment, which was I continued the eye drop because I was going to increase the dose of oral steroids. So I kept the topical and the oral steroids. I increased the dose of oral steroids. I started atropine, and I kept a pantoprazole domperidone combination for 7 days. So this is what happened when the patient presented after 7 days. You can see that as acutely as the symptoms started, they practically totally disappeared. So this is the picture in the right eye in straight gaze. This is in up gaze. This is in the left eye in straight gaze. This is in up gaze. You can see a small amount of serous effusion still persisting. The discs again point to CDR, nothing specific. And you can see that the serous effusion in the right eye has practically disappeared, and the CFT has reduced to 238 microns. The left eye also, there was a small amount of serous effusion remaining, and the CFT had reduced to 283 microns. So we have followed this patient up from 1 week, 6 months, 1 year. She's presently more than 1.5 years of follow-up. So in the right eye, you can see that the effusion is totally subsided. In the left eye also, the effusion is totally subsided. We eventually did fields, which were normal. OCT was also normal. At the present moment, the patient initially was on a combination of brimonidine and timolol, but now she's been on timolol for the past 18 months. Now, I had stopped the timolol, but the IOP seems to rise a little bit in the 20s. So that is my case, and I would like Dr. Dipanjan Pal as a discussant to take over, as well as Dr. Shibal Bharti and Dr. Ashok Nanda to discuss about this particular case. So I leave them with these questions, whether anyone has encountered a similar situation post-VKHD, post-PI in a case of VKHD, what could I have done differently? And has anybody faced a similar situation in a small eye, like the one I had shown previously in 2014? Thank you.
Yeah, Dr. Dipanjan, please.
Yeah, this is a real interesting scenario. Actually, there are 2 parts of it. One is that this is definitely this kind of bilateral acute angle closure situations following PI are because of sudden choroidal expansion, and that is almost always due to some inflammation of the choroid, or if it is a shorter eye, then there is either a sudden increase or decrease in intraocular pressure because of high spiral rigidity, and there is some externalization of fluid which is accumulated in the subcaudal space, and the presentation is like an acute ankylosing glaucoma. So whatever origin is done, it is fantastic, and it's a real good case to present. But I would just differ in one situation when it was already understood that this may be a case of ocular leakage where the ocular melanocytes are severely damaged, and there is almost there is always a subclinical inflammation in the choroid that goes on. So probably he could just to suppress the inflammation, he could start the steroid a week before, just to reduce the chance of exudative retinal detachment. This is number one. And number two, in my opinion, if the patient presents with such severe uveal effusion, at the first treatment, I would recommend intravenous prednisone acetate, solumetrol, intravenous solumetrol. So those are the two things I want to share.
So I'll bring in Dr. Shibbal here. Dr. Shibbal, are you there? Yes. Yes, sir. Yes, sir. Please, Dr. Pandav. Yes.
Actually, we saw a very similar patient a couple of years back. In fact, we have reported that case, probably general glaucoma. Don't remember exactly where, but that case was reported also. Following VKH, the patient developed acute angular closure glaucoma. And I think because his primary pathology is VKH, so we need to focus on that. So that means the primary treatment would be immunosuppression. It is steroid or whatever other immunosuppression is in the protocol in your institution. I think that would be the primary therapy. And of course, the pressure is high, so you need to control IOP. I don't think we did the laser iodotemy for that patient. I think that patient resolved with the systemic topical steroids and topical cycloplegics and anti-glaucoma medicines. And of course, once the disease was identified and managed, we didn't need to do laser for that.
Thank you, sir. Dr. Nanda, are you here? Dr. Nanda?
Yeah, I am there.
Yeah, so could we have your input, please?
Yeah, no, regarding the case, I don't know actually. It was for the nanophthalmus condition that he was mentioning in the first one.
No, sir, it is basically an open angle glaucoma.
21.1, I do not know whether it comes into a nanophthalmus eye. So that I do not know what is the reason for not getting published. And regarding the other second case, it is probably the inflammation induced cause for the effusion of the choroid, because it was inflamed eye, both post-segment inflammation and the acute congestive stage. So that was the reason why probably this was the reason for choroidal effusions to occur.
Thank you. Thank you very much. Dr. Shibbal, are you here? Her network was very unstable. That's what she wrote in the group. So otherwise, we move on to the next case. In the interest of time, we move on to Dr. Nazneen. Can you share your screen and present your case, please, Dr. Nazneen? Yeah, you're coming in spurts actually.
Shall I start?
Yes, please start. Go ahead.
Okay. So thank you, KAO, and thank you, Chandrima ma'am, for giving me the opportunity to is a 15-year-old male who was a factory worker by occupation. He came with the complaint of diminution of vision in both the eyes. He was diagnosed to have cataract elsewhere and was keen to undergo cataract surgery. He did not have any systemic illness, any medications or addictions. So examination, visual acuity in the right eye was 60 in 60, in the left eye it was 636 in 36. The chamber was deep and nuclear sclerosis showed grade 2 cataract, which was to be open angles. And the pressure in the right eye was 38 and in the left eye it was 34. There was no previous record of intraocular pressure measurement before. Funder showed a cupping of 0.9 in the right eye and 0.8 to 0.9 in the left eye. There were few drusen's at the macula, and the perimetry showed a biarcuate scotoma with threatened fixation in the right eye and incomplete biarcuate scotoma in the left eye. Patient on drugs, travoprost daily, and I wanted benzoylperoxide twice a day. At one, the pressure to 16 to 18 millimeters of mercury, at which point of time I planned to phacotrabeculectomy in the right eye in what I thought was a open-angle glaucoma. So I did mostly a two-side surgery, a rectangular flap. I did not use mitomycin C. I placed the IOL in the back and it was uncomplicated phacotrabeculectomy. So when the 612, the easy showed one else, there was a bleb. The IOL without bleb massage and without treatment, and post-operative started the patient antibiotic on eye drops 8 times a day to be able to atropine twice a day 15 days. So I was writing high on the cases because the visually what more could I have wanted, until suddenly a patient came with a sudden complaint of redness the last 4 to 5 days, at which point of time his visual acuity had reduced to 6/6. Slit lamp examination, multiple.
So here I'll bring in Dr. Shukarna, the discussant. Dr. Shukarna, are you there? She's not here.
Yes, I'm here.
Yes, please, please discuss the case.
Well, this is Nazneen's case is quite interesting, and I'm surprised that not more cases are reported in literature. She had a case of an advanced glaucoma with cataract. The patient had presented with cataract, but then she diagnosed advanced glaucoma, and she correctly chose to go ahead with a phacotrab. In these situations, I think it's very important to counsel the patient, lower the expectations for the results post-operatively. And fortunately, the surgery went off very well, and it was doing well until on the 4th week, the patient developed keratitis, HSV, epithelial keratitis. In these conditions, steroids are not indicated. So she was worried that her bleb might fail, but at this juncture, it is very important to keep the cornea clear. So the clarity of the cornea is more important than the bleb situation right now. So she did a good thing. She called in a corneal expert, and he started on the appropriate therapy, debridement and the appropriate antiviral drugs. And the patient responded. In this situation, she monitored the IOP and the bleb function. And if subsequently the patient does develop bleb fibrosis, she can go ahead at a later stage and perhaps do a needling or whatever. But at this juncture, it is very important to control the virus.
So your inputs, Dr. Mumtaz?
I think Dr. Nazneen did the right thing. She did the proper clinical examination. She went for the surgery. This viral keratitis following cataract surgery is we have seen in our practice. but viral keratitis following trabeculectomy is not that common. I would have recommended that she should, after the diagnosis of the viral keratitis, she should have reduced her dexamethasone topical application, tapered it as quickly, and she could have added the antiviral topical application, and she may have substituted the strong dexamethasone with a milder steroid like fluoromethanol, with a midretic like homotropine, and that would have solved the problem even more faster. But it was well managed case.
Thank you, Dr. Mumtaz. Dr. Shrutapa, your inputs, please. Dr. Shrutapa Roy.
We come across incidents of this kind of herpetic flare-up after prostaglandin use, but here it was not in use. It was stopped after surgery. So I think immune stressors like local cause like surgical trauma, inflammation, or steroid may be a cause, because primary herpes simplex infection is in 2/3 cases they go unrecognized. Or asymptomatic. So temporal clear corneal incision can interrupt corneal nerves and can trigger the reactivation. But it was managed early, and quick diagnosis was done, and visual recovery was also good.
Thank you, Dr. Shrutapa, very much. We move on to Dr. Pallavi Raj to present her case, please. Yeah, Dr. Pallavi, please share your screen.
Am I audible?
Yes, you are.
Very good evening, and a special thank you to Chandrama ma'am and the KAO for this opportunity. So I'm going to discuss a case of a 12-year-old boy who came for a regular checkup. His informant was his maternal uncle. He had progressive diminution of vision in both eyes. He had been wearing glasses for 2 years. He not shared.
Yeah, that's good.
So it's okay now?
Yes, perfect.
So a good evening, everyone. So I'm going to discuss this case of a 12-year-old boy who came for a regular checkup. His informant was his maternal uncle. And he had progressive diminution of vision in both eyes. He had been wearing glasses for 2 years. He was having a history of full-term birth. There was no other systemic complaints and no significant family history of any ocular or systemic diseases. He was not on any drugs. So coming to the ocular examination, the refraction in the right eye, his visual acuity was 6/60 in both eyes, and the refractive error was -5.25 spherical with -3 cylinder in the right eye and -6 spherical in the left eye with -2 cylinder. So refraction was rechecked and he improved to 6.9, but we see that the spherical error had increased to -8.5 in the right eye. The cylinder was, however, constant, and it was also the same in the left eye. The near vision, however, was N6 in both eyes. So coming to the slit lamp examination, there was peripheral anterior synechia in the supratemporal quadrant in the right eye and also in the infratemporal quadrant. In the left eye also, the supranasal area showed a peripheral anterior synechia. The AC was very shallow. It was grade 1 von Herig's. The lens was clear, but there was increased lens vault in the anterior chamber. So mild phacodonesis was also noted in both the eyes with a lot of focus. And the Goldman applanation tension was 26 millimeters of mercury in the right eye and the left eye was 22. So this was the slit lamp picture of the child. I did a gonioscopy for this patient and the angles were closed in both the eyes, and on giving compression, the angles opened to scleral spur in the right eye and in the left eye. The pus was present in the superior and inferior region. So I checked the fundus undilated. The disc appeared quite healthy with a vertical cup disc ratio of around 0.5 to 0.6 and a healthy neuroretinal rim. So coming to the key points of this case, he was a young myopic patient with a shallow anterior chamber, peripheral and central. He was having high IOP and he was having angle closure and there was lens bulge in the AC. So this all pointed towards a possible both eyes microspherophakia. So coming to the investigations, the CCT was 524 in the right eye and 521 in the left eye. Keratometry was done, the K1, K2 was 44 and 42.75 in the right eye. And in the left eye, K1 was 44 and K2 was 42.5. So this suggests that the astigmatism in the child was corneal and lenticular. Coming to the A scan, the axial length in the right eye was 22.12 millimeters and in the left eye 21.96. The lens thickness was 4.28 millimeters and in the left eye it was 4.62. And the AC depth was 1.75 in the right eye and 1.62 in the left eye. So I did a UBM for this child and this also showed a shallow central anterior chamber depth of 1.09. The sagittal diameter of the lens was 3.88 millimeters. The equatorial diameter was 6.04. There were elongated zonules which was deficient in the 7 to 9 o'clock hours. There was stretching of zonules. The ciliary body was small and the ciliary process was short. In the left eye also, the anterior chamber depth was 1.15 millimeters. The sagittal diameter was 4.10. The equatorial diameter was 5.71 and there was elongated sparse zonules noted all around. And stretching of zonules was noted with small ciliary body and short ciliary processes. So I came to a diagnosis of both eyes microspherophakia with angle closure glaucoma. Now, as far as review of literature of this condition is concerned, there are only, it's a very rare case, there are only isolated case reports, but there's one major study from India which studied 159 eyes in 80 subjects. This was published by Sirisha Senthil et al. In the Journal of Glaucoma in 2014. So here they say that the anti-glaucoma medication should be started for increased IOP with open angles. But eyes having synechial angle closure on gonioscopy, they should be treated with laser PI and medications. And if the patient was on maximum tolerated medical therapy in the absence of obvious subluxation, they required a glaucoma filtering procedure. And otherwise, we need to be cautious in performing TRAP for eyes with glaucoma in the presence of a subluxated lens. Combined lensectomy and trabeculectomy in these eyes could be an option. Pars plana lensectomy and anterior vitrectomy can also be performed for dislocated and grossly subluxated lenses that cause visual disturbances. So coming to the management in this case, timolol was started in both the eyes 2 times daily. The IOP dropped to 17 in right eye and 16 in the left eye. Both eyes laser peripheral iridotomy was done. Now, important point about this is we should not be giving pilocarpine eye drops because the miotic agents often aggravate pupillary block and they cause inverse pupillary glaucoma. And after this, after the successful PI, the patient was having stable IOP in both the eyes and he was advised to continue AGM, the anti-glaucoma medications. The patient was seen in February and he was asked to follow up after 3 to 4 months in June, which did not happen, however, because of the lockdown probably. But follow-up is very much required to assess the changes in myopia, the refraction, the lens stability, as these eyes are prone for progressive lens subluxation due to weak zonules. And we need to check the IOP, the angle status, and the disc changes. So here we can see that there was a little lens subluxation in the right eye, but the left eye did not show any such changes. The disc, however, was very much healthy, and even the red free did not show any RNFL defects. So thank you for your kind listening.
Thank you, Pallavi. There I call Dr. Moitri Das to please discuss the case. Dr. Moitri.
Yeah, good evening. It's a very good presentation indeed. Till now, the case is very well managed. So some of the things we should keep it in mind while examining this kind of cases, that young myope and having young myope high intraocular pressure as well as your gonioscopically, if the angle is narrow or there is some synechia, then only we should dilate this patient to see the lentil status. So these are the very important clinical tool for diagnosing microspherophakia, what you have done very well. Only thing is that always this kind of cases, you should keep a note on the gonioscopic marker, because the peripheral anterior synechia keeps on changing. If there is further progression and dislocation, I mean the subluxation of the lens, you should keep a record. And fundus photography also. So the disc, you should always keep record that how much it is changing. And in your case, this was absolutely healthy and the child is quite young. So keep a record of OCT RNFL, what I felt like, because the child will not be able to perform the automated perimetry. Another thing what I like to tell you is about actually the landmark of diagnosis is UBM, to find out the ciliary process state, ciliary body status, as well as your zonular status, that you have to find it out. And another thing is that always you keep a glaucoma baseline evaluation done, because these cases are prone for anguloclusive glaucoma in future. And you have to educate the patient party as the child is very young, how is the case is behaving, and anytime might need some emergency and myopia will increase. You have to keep giving them the proper refractive corrections, and follow-up is very important, that you have to make the party understand. Thank you.
Thank you, Dr. Maitri. Here I'll bring in Dr. Ankur. Dr. Ankur, are you here?
Yeah, ma'am.
Yes, so there's a little correction in Dr. Ankur's CV. How can we forget that he's from Jaipur and not Dehradun after the royal treatment he gave us at the GSI in Jaipur? Ankur, indeed, we are sorry about saying that you're from Dehradun. Jaipur, we remember very well the Jaipur in the GSI at Jaipur was fabulous, and thank you very much once again for that. And he's at Max Vision Eye Care Center and is an MD from the RP Center, Delhi. So with that, Ankur, your inputs for this case.
Thank you, ma'am. And all the while, I was wondering that how could you reach my in-laws actually? My in-laws are from Dehradun.
That's probably why it happened.
So I'll just say, I mean, Dr. Pallavi has nicely managed this case. What I would say is, like we had discussed over the phone also, that we should always look at the cylinder in these cases clinically. Because if the cylinder is matching with the corneal kind of astigmatism, then probably we are having little bit, kind of stable zonules, or maybe there is more of a subluxation, which we are going to miss. Another cause of cylinder in these patients could be a posterior staphyloma. And these patients can actually have various mechanisms of glaucoma, like they can come to us like an acute attack, they can have chronic angle closures, they can have a movement of the lens forwards causing these peripheral anti-synechiae, or maybe at times you can have this dysgenesis of the angles which can cause glaucoma. So most of the times we get these patients where the lens is actually moved forward, and then we have to actually do a lensectomy to settle down the glaucomas. But this patient has been very nicely managed in terms of medical management. And clearly we can see that the axial length is not too much, corneas are not too flat. So we don't have kind of significant refractive error because of the corneas or the axial length. So the myopia the patient probably is having is because of the increased anterior-posterior diameter of the lens. So everything fits into this significant kind of microspherophakia. And a regular follow-up, as Dr. Maitri has already said, that we can kind of do a follow-up RNFL, because we would not have a normative database for this patient because he's less than 18 years of age. But we can serially follow whether the nerve fiber layer is actually thinning in this patient. So if it is causing a thinning of nerve fiber layer, then maybe we can think of worsening of glaucoma in these patients.
Thank you, Dr. Ankur. Can I call Dr. Sagar Bhargav for his inputs? Dr. Sagar? Dr. Sagar, are you here? Yeah, there he is. Yeah, Dr. Sagar. Go ahead. Is there a problem in the network? Yeah, okay.
Hello. Can you hear me?
Yes.
So one good point in this case is that even gonioscopy can be done in children. So that's a point that one should highlight, that just because it's a child you should not do gonioscopy, that because that can be a clincher, because every shallow anterior chamber does not mean that you have an angle closure. So you have to document that angle closure by doing a careful gonioscopy even in children. So that's a very important point. But then just doing a YAG PI, post YAG PI also the gonioscopy has to be done every 6 months to make sure that the progressive angle closure is not happening. Because if the angle closure is happening, the best thing is to do a lensectomy, and then take it from there. Because if then that might avoid us a possible glaucoma surgery for that patient. So angle closure in a young patient is always should be seen in a different context and look for secondary causes. Especially in this case, there was no systemic associations, but we should always remember about Marfan's Welch-Marchesani syndromes or other syndromes which can actually have zonular weakness and cause shifting of the lens forwards and progressive myopia and angle closure. I think that's what I would like to say. Thank you.
Thank you. Those were great inputs from all three of you. Now we move on to the last case. Dr. Tamanash Basu, can slit lamp help? Can you present your case? Can a SLT help?
Is my screen visible, ma'am?
Yes, yes, yes.
A very good evening to everyone. Thank you, Chandrima ma'am. Thank you, Kolkata Academy of Ophthalmology, for giving me the opportunity to speak here. So I'll directly go to the case. 53-year-old male presented to us with a complaint of diminution of vision for last 1 year, left eye more than right eye. He's a known hypertensive and had CABG in the past. He was diagnosed glaucoma elsewhere and was started on latanoprost both eyes. The baseline intraocular pressure was not known. There was no family history of glaucoma. So in the first visit, when we did the ophthalmological examination, the best corrected visual acuity in the right eye was 66 N6 and in the left eye it was 660 and N12. The anterior segment was within normal limit in both the eyes, and left eye had a LOCS3 grade 2 nuclear sclerosis with PSC. The gonioscopy was the angles were open in both the eyes. The intraocular pressure was 12 mm of mercury in both the eyes. The pachymetry was 512 and 513. On 90-day evaluation, the disc showed VCDR 0.5:1 with IR thinner than SR in the right eye, and in the left eye, VCDR 0.65:1 with IR thinner than SR. The perimetry showed right eye almost normal fields, and in the left eye, some paracentral defects were there. So with this history, because of the cataract, the patient underwent uncomplicated cataract surgery in the left eye with a placement of foldable intraocular lens in the bag. For the initial postoperative period, the PG analog in the left eye was shifted to beta blocker. And when the patient came back to us for the glass appointment after 3 weeks, the BCVA was noted to be 66 N6 in the both eyes. The anterior segment was within normal limit in both eyes, and in the left eye there was well-placed foldable intraocular lens in the bag. The gonioscopy was open, but in the left eye the intraocular pressure was noted to be high, 26 mm of mercury. So we added prostaglandin analog along with beta blocker in the left eye, and the patient was kept on regular follow-up for left eye intraocular pressure monitoring. But the left eye pressure never came under control and continued to rise despite addition of topical anti-glaucoma medication. This is the line chart showing right eye and left eye intraocular pressure. The left eye showed that increase in the eye pressure. First, we added the latanoprost. Still, when the eye pressure was not controlled, we added a beta blocker free combination, and still the eye pressure was not controlled. In the final visit, when we saw the patient, the BCVA was 66 N6 and the left eye was 69 N6. The anterior segment was within normal limit as usual. The lens was well placed in the bag in the left eye, but the eye pressure was 30 mm of Hg with maximum tolerable medication. And with 90-day evaluation, we saw glaucomatous progression in both the eyes, VCDR 0.6:1 in the right eye with a disc hemorrhage in the inferior border, and in the left eye 0.85:1 with bipolar thinning. This is the colored disc picture of right eye and left eye. The right eye showed the disc hem in the inferior margin, and left eye with 0.85:1 bipolar rim thinning. The GPA analysis showed likely progression in both the eyes. So with this history, as the eye pressure was not controlled with maximum tolerable medication also, we had to do some intervention, but the patient was very apprehensive for the surgical intervention. So we did a 360-degree SLT. These are the parameters. And after the SLT, we added flurbiprofen for 3 times per day for 5 days, along with all the anti-glaucoma medications. And when the patient came back, the eye pressure was fairly controlled. We had a 3 months follow-up after the SLT was done, and we have reduced the anti-glaucoma medication to 2 anti-glaucoma medication now, and the eye pressure is fairly well controlled. So fairly young, the patient was myopic with a -8 diopter of myopic correction. Fairly young myopic male patient with fairly well controlled glaucoma in both eyes, underwent cataract surgery in one eye. Then the IOP was uncontrolled after the cataract surgery, which was eventually managed with SLT. So we did some literature review about the outcome of SLT in pseudophakic patients, and we saw that in pseudophakic patients, it doesn't act that well. It acts in the phakic patients. In this paper, actually, they have given the cause also. It may be because the SLT and CCP shares the common pathway. That's why the SLT doesn't work that well in pseudophakic patients. So with this history, we are now faced with some questions, like what is the cause of sudden IOP spike after the cataract surgery, and what precautions should we take for the other eye surgery, and what else could have been done, and how frequently we should manage this case after the SLT is performed in this patient.
Thank you, Tamanash. Here I bring in Dr. Kavita. Dr. Kavita, please discuss the case.
Thank you, ma'am. Thanks for the opportunity, Dr. Tamanash, for the great presentation. I think it's a clear case of glaucoma in myopia. As noted in the presentation, we can see from the fundus picture itself, like the extent of the tessellated background and the extent of the peripapillary atrophy. And I feel the progression is not happening only in the left eye, and it's very much happening in the right eye, because to start with, you have mentioned a cup disc ratio of 0.5, and in the final picture, whatever you showed, even in the right eye, I think it's around 0.65 with the inferior disc hemorrhage, and you can see very well that has progressed in the left eye also. And I think it's a good fundus picture for learning also, to look at the parapapillary atrophic area. You can see, though both the eyes, I think he has not mentioned the extent of myopia in both eyes, and also the axial length has not been mentioned, and we can see, but still the peripapillary atrophy is like more extensive in the left eye. And I think axial length is one factor which we have to keep in mind in these cases, because studies have shown that that is one of the risk factor which can make the patient more prone for myopia also. And because of the elongation of the eyeball and the stretching of the lamina cribrosa, they are more prone to progress also, depending upon the axial length. With the refractive correction in the field, it was around like -10. You also, like the patient had like around -8 diopter myopia. And I think considering the causes during the cataract surgery, these eyes tend to have a reverse pupillary block on the table. So we need to take care to reduce the reverse pupillary block. That can be easily done with the help of a Sinski hook, just lifting the iris up, or you can even have a nasal iris hook, so that the fluctuations of the chambers during the surgery should be avoided, and the reverse pupillary block should be avoided. So probably, I don't know whether these precautions were taken in the left eye. And I think doing SLT in these eyes is just a stopgap arrangement, like when a patient with a pregnancy or lactation, when we want to avoid surgery, and when the maximum medical therapy also is not helping, we do SLT in those eyes. I think here also the situation is something similar to that. I think the patient will definitely need a surgical intervention in the left eye, and also which may be a trap or maybe a tube, whichever is like best in your hands. But again, while doing a trabeculectomy, we have to make sure to take proper precautions, because it's a myopic eye. We can't generously use mitomycin. Probably other mood modulators like collagen implants, like Ologen, will be helpful in these situations. We need to be very careful while dealing with the flap, because these eyes tend to have thinner flaps. There's chances of hypotony, and all these complications can happen. And I think again, while doing the cataract surgery in future in the right eye, that has to be taken care of. And I think as of now, the case has been managed very well. But again, these cases need to be, as rightly asked, as one of the question, more frequently. I think we had one of the presentation by Mayuri madam about follow-up of cases and the management of cases with advanced glaucoma. This left eye very well fits into that category. And as we follow the advanced glaucoma cases, maybe once in 3 to 4 months, the left eye needs a follow-up, and we need to keep the IOP maybe less than 12 millimeters of mercury and assess progression continuously. A frequent field examination is a must. And again, in myopic eyes, not only the disc damage will contribute to the field, the peripapillary atrophy, the like a deformation of the disc and the chorioretinal degeneration, everything will contribute. So the proper assessment is needed. And as this has to be followed up with the fields, as we know, like OCT will show a red disease in these eyes.
Thank you, Dr. Kavita. That was really wonderfully discussed in detail. Thank you for giving us such details of the case. Really wonderful. Here, I'd like to bring in Dr. Rita Das for her input, please. Dr. Rita, are you there?
One thing I want to emphasize, that is, it might be a case of steroid-induced glaucoma post cataract surgery. It might be he might be a case of steroid responder because he's myopic, so a very high chance. So that should be kept in mind. So that case SLT, I don't know how much it will work. Second thing I want to point out, post CABG case. So giving beta blocker. I would I would prefer carbonic anhydrase inhibitor or alpha 2 agonist. Another thing is giving latanoprost also, prostaglandin analog. 30% people, as we know, they might be non-responders. So those things we have to keep in mind. And SLT, I think, is not a very good option. I would like some other medical management, not beta blocker, not prostaglandin analog. Either first line of therapy will be carbonic anhydrase inhibitor or alpha 2 agonist or combined drugs. Or if it is not well controlled, it's progressing, then I would prefer surgical option.
Thank you, Dr. Rita. Dr. Somendra, we need your inputs, please.
Yes, first of all, I like to congratulate Dr. Tamunes, a very nice presentation. And for your first questions, I totally agree with Dr. Rita Das. Rita rightly said it may be a possibility of a steroid responder. And you did right, if the patient is not going for a surgery and additional treatment you have to give, that is SLT can, of course, it can be reduce the intraocular pressure in what has been done here. And it's well managed. But the problem with SLT is that in the long term you have to follow up because its efficacy reduces as the time goes by. So ultimately you have to go for a surgery that the Kavita madam already discussed. So nice presentation.
Thank you. Thank you very much. So Kamanish, can you just stop sharing your screen, please? Yeah, then we'll have everybody on board. And Dr. Shumit Chaudhary wanted to ask something. Where is he?
Chandrima, can I say one thing?
Yes, please. Yes,
sure. I am using a lot of SLT. In younger patients, the SLT has a very little role. It will not work. SLT functions when you have a matured trabecular meshwork. In juvenile cases, the trabecular meshwork is not matured or well developed, and that's why the glaucoma starts early. So SLT, the mechanism is to clean up the debris. So maybe SLT may not work for a long time in this patient. It could be for a small period it functions.
Thank you.
Yeah.
Thank you, Mayuri. Just one question is coming up. This is the medical forum now. The generic versus the MNC drugs. The generic drugs has changed for the few years back. What was before 10 years back, what is in 2020. If we give a preference in the four corners of India, I want to ask the different doctors, are you satisfied with the generic drugs? Yes.
I would like to
Sure.
I would like to comment here. I'm Dr. Shefali.
Yeah, hello.
Because I discussed generic versus brand. So actually, see, I personally prefer brand, but yes, sometimes if the patient cannot afford, and then we can start generic. But one thing I always explain to the patient, because generics, there are a lot of what I discussed in my talk also, that sometimes bottle, sometimes the tip of that hole of the bottle may enlarge over a period of time. There is a lot of wastage. Plus, the side effects with the generics are also more. And if you see now the good companies generics, actually the cost of those generics are at par with the brand. So considering all those points, if you explain to the patient that if you are putting the brand and the cost, actually I haven't published the study, but actually I compared one brand, which is a very commonly used brand, with the generic, and I found that the brand, where patient was able to put the brand, it had patient able to use it for around 32 to 35 days, compared to the generic that I did it for like continuous consecutive 2 bottles. I gave the patients, and exactly in a 17 to 19 days, the generic bottles they finished. So actually, if you put that, if only the cost is an issue, and if you consider those points, and actually the brand comes out to be much reasonably at a better option compared to the generic. But yes, sometimes if some patients are not able to afford and then you may start with the generic, because it's not necessary that brands are available everywhere. So generics can be started, but personally, if brands are available, I prefer that.
Yes, one paper has already come before that. If you take the 1 year consumption of the generic and 1 year consumption of brand, the number of bottles used in the brand is less, and the total number of the cost is also at par or little. That's right.
See,
Okay.
can I say a few words?
Dr. Pandav, yes, sir.
I think when you talk about the generics or branded drugs, I think you also have to consider the molecule or the drug that you are talking about, because certain molecules are easy to reproduce. They are very stable molecules, and it doesn't matter much to their stability and pharmacological actions if one company makes them or the other company makes them, as long as some reasonable pharmacological equivalence is maintained. And give you an example, timolol is a good example, because timolol actually goes well with most of the other drugs combinations, and also it will tolerate the vehicle very well. So if you are making a timolol which is generic, it will work very well. So there should not be a lot of as long as the dosage is maintained. So, but on the other hand, you have molecules which are very sensitive to manufacturing process, and prostaglandin would be a good example for that. Those are the complex molecules where the temperature, sensitivity, the pH, and other things, they are very critical. So if you have a molecule which is very sensitive in nature, which is not very stable, there you have to be careful when you use generic drugs. But if you have a molecule which is stable, which can be easily replicated, I think you could consider a generic brand in those situations.
Sir, yes, I just wanted to say two things.
Yeah.
The thing is that whenever I get the sample of a new drug, generic drug, I do two things. I empty one bottle in front of me. I count the number of drops it has, and I see on how much pressure, how many number of drops they fall off. Sometimes there are companies in which you want one drop to be fallen, but there are 3 drops falling. So this is what takes care of what Shefali said, that it lasts for so many days. So I do it in the first go itself, right in my clinic, and do it with my own hands. And on a paper, I keep on writing that this brand of this medicine gives so many drops per month. So that is one part of the story. The rest of the thing is that I agree with Dr. Pandav that it depends on the molecule. And I feel that as far as the drug efficacy is concerned, most of the generic brands in India, the good ones, generic companies, they are giving very good quality product. The differences are in 2. One is about the packaging. As I said, I count the number of drops, how much it actually comes. And second is about the drug allergies, especially with the brimonidine group of drugs, in which as such the allergy is very common. And in some of the generics, the allergy is far more common, and stinging sensation is far more. They are more uncomfortable to use. So probably there is a vehicular problem of the vehicle rather than the problem of the active molecule per se.
Professor
Thank you.
Yes, sir. Yes, sir. Go ahead.
Hello?
Please to unmute. Unmute.
Sir, Dr. Das, unmute, sir.
Yes.
Yes, sir.
And a country like India, we encourage generic preparations. Cost is certainly a factor, but when you consider a generic preparation, it should be effective. That is, and ultimately it should be cheaper, or should be price should be okay for the majority to afford. But when I'm talking about the generic preparations, let us talk about the drug formulation. We have got the major component, say timolate maleate, right? For the preparation, you need a pH. To maintain the pH, we need another substance. To maintain its viscosity, we need another substance. For the preservative, we need another substance. For the penetration, we need another substances. So there are 7 more components or elements used for a particular medicine to be effective. We need to be very sure that each component is pure, each component is really passed the test of the manufacturing unit, and there is no interaction between the two. The drug compatibility between the components drug is also very important. Unfortunately, in India, we do not have an institution, government or even private, to check each and every component that is going to make a drug, including their main ingredients and the other things. And there absolutely no laboratory to test it. So that is what is restricting us to use a generic preparation. Otherwise, we in fact we should encourage generic preparations for the most of our Indian people to use it more comfortably. We must be very sure that the purity of the
I
drug.
would like to make a comment here.
Yes, please carry on.
I agree with Dr. Das completely. Actually, I just want to add, not only in India, even in US FDA, for the points that you sir told you told about that pH, viscosity, buffer, and everything. These are inactive ingredients which actually form nearly 97 to 99.5% of the drugs, which is the main bulk of the drug. And actually, this inactive ingredient in the generics, if in generic they, even if it doesn't match to the brand, then also it is permissible even by US FDA. So the components which form the main bulk, they need not be the same, and that is one of the reason that that affect this potency and the particulate contamination and all the factors that I discussed. Because of all those factors, actually they are not within the limits in the generics.
Okay.
So basically,
Can I go for
these generic drugs are biosimilar. Only for ophthalmic drugs it is allowed as a biosimilar. These companies are not supposed to perform any studies before they enter the market.
That's right. Yeah.
Okay, that is the problem. The safety studies never been done by them also.
And they just wait for their study and they go for the production.
Wait for trials, that is once the thing comes in the market, that is done later on after using those. So in India, that is the issue. While in US FDA, generics are allowed. 90% market is for generics, but they have to produce some studies. They are not only biosimilar. That is the difference between the Indian generic and the US FDA.
Okay.
Yes.
The
molecule is same, but the incipients, the rest of the things, so many things are there. Dr. Das has said so many things. They are different in each generics. It is not same because it is a patent right. So they don't know what is the amount and what is the pH is being.
It is depends on the R&D of that company also.
Yes.
Perfect.
That
We
is
all agree on those.
generic though is cheaper, but eventually it comes to same as the branded drug because the side effects are there. Then it induces dryness of eye. You add the dry eye preparations or the treatment, or frequent follow-ups are required because you have started generic. You have no confidence in that medication, so you would like to see patient more often. That also increases the travel expenditure. So maybe if we don't consider that much to the cost, we can use branded if possible.
Okay, thank you. Ankur, just one last one for
Yes,
you.
sir.
On one corner, another corner.
So, like for this generic versus these things, I usually give the example of this common salt to the patient. Like it is available in the packaged form and it is available in the open form. So you test the common salt in both the things, you will have 100% NaCl. But the ingredients added to it are different. So most of us usually buy these packaged common salt, maybe a Tata salt or whatever. So most of the patients do understand the differences of the additives into these medicines which we are talking about. Otherwise, how we can explain these things to the patients? It is difficult to explain.
Thank you very much. Now it's a shortage of time and it's already
We're
time.
over to our organizing secretary of the conference, Dr. Rajesh Majumdar Chaudhary. He's waiting there patiently for us to finish the discussion.
But you know, I must say that I'm learning a lot. Being an oculoplastic surgeon, I don't really get a chance to listen to all this, speakers. So thank you so much for letting me stay on and listen. Thank you, ladies and gentlemen. As part of our Annual Congress 2020, we have designed this bouquet of talks on various aspects of glaucoma diagnosis and management. And today was our penultimate talk. We're indeed proud to have such an accomplished team of speakers and presenters as part of this program. My sincere thanks to each member of the faculty for making it so enjoyable and so lucid, mostly. A big kudos to executive committee members, especially Dr. Surajit Chakraborty, Dr. Chandrima Paul, and Dr. Shumit Chaudhary for this brilliant meet. I thank you, three of you, on behalf of all the members of Kolkata Academy for letting us this opportunity. I must thank Sun Pharma Melbourne Division for the logistical support. And last but not the least, a big thank you to Mr. Puneet and Ms. Chetna from the technical support team. Friends, it's time to say goodbye, but I'll not say goodbye, I'll say au revoir, because I want all of you to log on again next week for the last part of our program. Don't forget, Saturday next week. Thank you so much for your patience.
Thank you. Thank you, everybody.
Bye-bye.
Thank you, ma'am.
Thank you.
Thank you, everyone.
everybody.
Good night. Nice being here.
Good night.
Thank you.
Stay well.
Thank you very much.
Well conducted.
Stay well.
Really, I enjoyed the whole show.
Thank you very much.
Very, very well conducted webinar.
Yeah, very well.
Thank you so much.
Thank you very much.
Good,
Thanks.
good night.
Thanks.
Bye.
Thank you.
Stay well.
Good night, everyone.
Stay well.
Stay safe.
See you, everybody.
Bye.
Yeah,